sí. Sí, ahora.
And good morning, everybody. Welcome to this morning session, this live discussion with three excellent key opinion leaders that will discuss fluid therapy, renal replacement therapy, and ECMO. My great pleasure to welcome Professor Xavier Monet from Paris. Most of you already know Xavier from his seminal works on hemodynamic monitoring. Professor Marlies Osterman from King's College in London. And I know all of you will know Marlies from also her seminal works on renal replacement therapy and acute kidney failure. And Associate Professor Dieter Dahl, who is an expert as well as a fantastic educator in extracorporeal circulation. And congratulations on a really well-run course on ECMO this Congress. So welcome, everybody. My name's Michelle Chu, Professor of Anesthesia and Intensive Care in Linköping University Hospital in Sweden. So let me just start off and lay the basic foundations of today's discussion by asking you, Professor Monet, what are your two most important key messages that you want to tell the audience today about hemodynamic monitoring and fluid therapy?
Thank you very much, Michelle, for the kind introduction. First, I think that my main message would be that we should monitor our patients. I mean the complex patients we have, critical ill patients, severe patients, these patients where we want to know what happens. It is not possible to know what happens spontaneously or with the treatments we use if we do not monitor the patients. And it's especially the case for hemodynamics. If you do not monitor cardiac output when you give fluid to your patient, when you give dobutamine to your patient, you don't know what happens. If you don't monitor tissue oxygenation, SVO2, lactate, PCO2 gap, you don't know the effect of your treatments on tissue oxygenation. And it's really my key message. We have several devices today, several ways, several variables to measure, but we should use them. Of course, some of them are complex to understand, and that's why teaching is important and research is important to know how it may change with it or that treatment, but we should see what happens in our patients. Regarding fluids, it's especially the case because we know that the effects of fluid are very transient. They are not only inconsistent, but also very transient. So definitely for fluid administration, we should monitor what happens in the most complex patients.
Okay, thank you for that. Marlies, did you want to comment on Xavier's recommendation? Do you monitor all of your patients?
Absolutely, yes. Thank you. It was great to listen to Xavier, and I fully agree with Xavier. Monitoring, and I would add re-evaluation, is key to the management of sick patients. And very often we're not exactly sure what to do, so I think the aim is to do one thing and then re-evaluate, and not to be scared that this may not be the right decision, but then turn around again and take a different approach and then re-evaluate again. So constant re-evaluation of our strategy and management, I believe, is the key to critical care and achieving best outcomes. And this applies to the sick, critically ill patient without kidney failure, but in particular those with kidney failure and hemodynamic instability.
No, I think you hit the nail on the head there. It's not just about the monitoring, which is obviously the first step. That's what you need to start off with. But it's also re-evaluating and your response to monitoring that is going to make the difference. Dieter, did you want to comment on that, especially within the setting of ECMO? I will come to that a bit later on because I know there are difficulties with monitoring when you have a patient on ECMO, but would you like to tell us how you monitor your patients?
Yeah, of course, like ECMO, the sickest of the sickest patients we have in the ICU. So hemodynamic monitoring is, of course, of paramount importance in our ECMO patients. But like you told already, a lot of the devices we regularly use, like, for example, thermodilution cardiac output, are invalid in our ECMO patients. So there are a lot of issues. So it's difficult to monitor the sickest of the sickest.
Xavier, can I ask you a very controversial question, and it's, I'm not looking for a black and white answer. But if you had to pick, you have a patient in front of you with vasodilatory shock, what is your monitor of choice?
We have several monitors today, and so that's good because we can choose. Some of us use what one calls the sophisticated monitoring devices, the Pico device or the EV1000 device, both are the same. The old pulmonary artery catheter, which should not be forbidden because it's very interesting. It provides outstanding physiological variables. And some of us use only echo. My opinion is that it's difficult to monitor a patient with echo because it does not allow you to perform a continuous monitoring. And at least in my practice, it's difficult to repeat echo that often. And this is why, in addition to intermittent echo evaluation, I use a continuous monitoring with Pico in some patients, with pulmonary artery catheter in some other patients. But the worst you can do is to do nothing.
I couldn't agree more with that. Thanks. And Marlies, within the context of a patient with acute renal failure that's perhaps on renal replacement therapy, are there any particular monitors that you would or wouldn't recommend? What are the do's and don'ts?
Michelle, that's a very, very important question. Clearly, renal replacement therapy is an integral component of critical care. So we use it routinely in most critical care patients. We have new evidence from landmark studies, and our knowledge has clearly improved. But these studies have also opened up areas where we don't have experience or knowledge. So they've revealed all these gaps in knowledge and areas where we potentially also cause harm. And this brings me to this concept of dialysis-induced kidney injury, which has now arisen as a result of all these trials which have been confirmed and done. And dialysis-induced kidney injury essentially refers to the fact that renal replacement therapy is associated with harm, including hemodynamic instability, which may or may not be preventable. We can talk about that. And that this degree of hemodynamic instability or dialysis-induced kidney injury may reduce the chances of kidney recovery. So it is, there is currently a lot of concern that the way we manage renal replacement therapy, especially if we do it without monitoring, may reduce the kidney's chances to get better and may contribute to prolonged acute kidney injury and possibly even prolonged chronic kidney disease and early end-stage renal failure. So if you, for instance, go to the START-AKI trial, which was a timing trial, this trial showed that patients randomized to early initiation of renal replacement therapy had a significantly higher risk of being dialysis dependent at 90 days. It's currently not clear why this happened, but at the same time, this group of patients also had much more hemodynamic instability, so there were more adverse events in this group. And this raises the question whether our practice of doing renal replacement therapy and potentially allowing swings in blood pressure or taking fluid off too fast or not fast enough contributes to the long-term complications. So it's a long-winded answer to your question. Yes, monitoring is absolutely essential. What we haven't got consensus on, what we should monitor, how we should monitor it, and how we prevent this new concept of dialysis-induced kidney injury. And clearly, these studies have opened the door to many more studies which urgently need to be answered.
Thank you for that, Marlies, and it wasn't long-winded at all. It just exposes the complexity of all the issues that we're dealing with in intensive care. A lot of the therapies that we have assumed to be bread and butter for, a very sick patient are now being questioned. So I appreciate that. Thanks very much. And I know, Dieter, you also have some of the same sorts of feelings with the hemodynamic monitoring in patients that are treated with ECMO. Can you expand on that?
Yeah, maybe we can discuss two issues. For example, monitoring of perfusion. I mean, we standardly use thermodilution cardiac output. The problem on ECMO, and the literature is mainly there for VV ECMO, is that you drastically overestimate your cardiac output because you lose part of your indicator into the ECMO circuit. And this is quite extensive. I was actually surprised. Like in a standard FEMJUC ECMO configuration, if you run a standard flow of 40 to 60% of your cardiac output, you actually overestimate your cardiac output by 2 liters. And this is actually increasing with increasing your extracorporeal blood flow. So that's actually quite a lot. And yeah.
Absolutely, you're right. It is true that the two most sophisticated and most informative devices we have to monitor cardiac output, namely the pulmonary artery catheter and transpulmonary thermodilution, do not work in case of ECMO because of the extracorporeal circuit. And it's all an issue of the flow, because during renal replacement therapy it works because the flow, of course, is much lower. But in the sickest of the sickest, as you said, we don't have these devices. It's really an issue. By the way, it is really in these patients that monitoring with echo as often as possible is mandatory. Other devices might be used. You know, we have these bioreactance devices, but are they informative enough, reliable enough? I'm not sure in these patients. You're right, hemodynamic monitoring in these patients, even with VV ECMO, is definitely an issue.
If we continue a little bit on monitoring perfusion, like basically, if you have a look at pulse counter analysis, cardiac output, of course for VA ECMO it's not possible because pulsatility is due to your partial bypass minimal or absent. But what's your opinion, for example, during VV ECMO? Because there you don't really influence the trace of your arterial line. So what do you think about that?
It's a very good point, and we are performing a study to see whether pulse contour analysis without calibration, of course, works in case of VV ECMO. Indeed, I cannot conclude definitely. It seems it works, but there is no calibration. So it means that for assessing short-term changes in cardiac output, it may work, but you don't know the absolute value of cardiac output because it's not calibrated. Note that there is a possibility, which might be to calibrate with an external device, as with echocardiography, it's possible on some devices. So to use an externally calibrated pulse contour analysis, I think it might be a solution in addition to echo.
Besides perfusion, I mean, the other difficult issue is, of course, monitoring fluid responsiveness, because all the dynamic parameters that we normally use, PPV, SVV, like in VV ECMO, we can't really use them because we go to ultra-protective ventilation with very small tidal volumes. The lungs are also really stiff usually, and most of the times you also have a degree of RV dysfunction, so that's also a big issue to monitor during VV and of course during VA, because there you don't have a pulse or minimal pulsatility.
In VV ECMO patients, what we use is passive leg raising and the mini fluid challenge monitored with echo on the velocity time interval, because you cannot use lung-based, ventilation-based tests and indices, as you said, and you have not any continuous monitoring of cardiac output, as we said before.
Well, I think one of the important take-home messages that I've gotten from all the courses that the three of you have been running is that there is not one single monitor that is going to fulfill all of your needs. And this is something that I want to say to the audience as well. There is no one go-to monitor. The monitors will all do different things. They will be specific for different purposes, and they will complement each other. So if we come back to our patient with sepsis on renal replacement therapy that we are perhaps considering VV ECMO on, you know, the continuous monitoring will be an excellent monitor to tell you if there is a deterioration. This is something that you won't get with echocardiography unless you repeat your examinations very, very often. In terms of, and of course there are caveats to the transpulmonary devices as well as the pulse contour analysis that I'm sure, Xavier, you can tell us a lot more on. And with regard to echocardiography, I think that is absolutely essential when you have a suspected right heart failure, which you won't pick up with your continuous devices. Xavier, did you want to comment on that?
No, you're right. You're right first by saying that all the devices have their drawbacks, advantages, limitations, including echo. What is important when you use echo is to be aware of the precision of the technique, because when you repeat measurements, you must know the smallest change that you may detect with that or that device. Echo is not very precise, and for instance, these are very practical issues. When you remove the hand and the sensor from the patient, the smallest change you can detect with echo in VTI is 10%. It's quite high. If you keep your hand on the patient with the echo beam in the LV outflow tract, it becomes much better. 4%, roughly 5% is the smallest detectable change. It has some very practical issues when you perform, for instance, a passive leg raising or a mini fluid challenge. It's better if you're sure that you measure exactly the same thing before and after the test. Provided that you take care of that, you have something that detects the short-term changes in cardiac output quite reliably.
Xavier, what do you consider a mini fluid challenge? Is it 100 mLs?
We have more and more studies showing that it's a good way to predict fluid responsiveness. Two issues. The first is that if you look at all the studies, we have different thresholds. We need more studies to know precisely what is the threshold of cardiac output increase that will tell you the fluid responsiveness with typical definitions. The second point is the precision of the technique. And I see some colleagues that, again, do echo, give 150 mL of fluid, go away and come back and do the measurement again. It's not a good way to do. Again, you must infuse fluid very rapidly. We do that with 2 syringes of 50, one after the other, and keep the hand on the patient. So it's not that easy, but provided that you do that, I'm pretty sure it's a good way. Of course, if you repeat it and repeat it, it leads to fluid overload. But provided that you do that not repeatedly, it's a good way to assess fluid responsiveness.
This is also really crucial, like for VA ECMO weaning, where you also need to have really accurate VTIs during your weaning trial. So, like Xavier said, it's important to have a stable position of the probe during your weaning trial. Otherwise, you have too much variability in your measurements.
The same, absolutely.
Marlies, one question that I quite often get from my colleagues is, are the monitoring techniques that we normally employ, such as, pulse wave analysis, this is probably the method that we would most often employ in our ICU, how reliable are those in patients who are under renal replacement therapy?
That's a good question, which I don't think I can answer. And I think Xavier or my colleagues here have much more experience. What I do know, what I can comment on, is the use of these devices to look at kidney function. And I'm sorry to tell you that they are not useful at all in monitoring the health of the kidneys, whether the hemodynamic status is adequate for kidney function, and more importantly, whether it's inadequate. And there is increasing evidence clearly that the kidneys need an adequate renal perfusion pressure, which depends on the systemic blood pressure and the cardiac output. But it also depends on the pressure in the renal veins, which is affected by CVP and intra-abdominal pressure. And there's increasing, still limited, but increasing data now showing that the renal perfusion pressure, as the delta between MAP and renal pressure, is probably more reliable. And at the moment, none of us measure this. And it can't be assessed even if you do the echo and if you do the most sophisticated monitoring device. So I do believe we need to include tools or measurements in addition to all the sophisticated hemodynamic tools which are in use to look at the health and hemodynamic optimization of individual organs, in particular the kidney, which relies really on renal perfusion.
I'm glad you brought that up because we quite often talk about upstream pressure, you know, the perfusion pressure, cardiac output, and those sorts of things. But the downstream pressure is actually very important as well, not least in the kidneys.
Absolutely.
And there are new methods coming up that will assess that. One of it is, perfusion in the renal veins. The whole splanchnic circulation VEXUS is a really new and interesting method that may help us. I don't know, do you have a comment about how we might assess hemodynamics within that context?
I fully agree with Marlies that for the kidney, the most important is the perfusion pressure, not flow. The renal function depends on mean arterial pressure. And of course, monitoring blood pressure is part of this sophisticated monitoring we need. Also, I agree with the message that CVP is a fundamental hemodynamic variable that many colleagues do not monitor anymore. Do not monitor anymore because we know it does not predict fluid responsiveness, but it costs almost nothing. And for the kidney, measuring the perfusion gradient between mean arterial pressure and CVP, taking into account the intra-abdominal pressure, is key, definitely key. Then we need some studies to know the thresholds that must be targeted for improving the renal function. And we have a study on that. But definitely, CVP, the very simple CVP, is part of the sophisticated monitoring we need, especially for the kidney.
If I could just add one comment. This is important for patients at risk of acute kidney injury, but it's also important when people are already on renal replacement therapy. And it is very upsetting when when colleagues put patients on renal replacement therapy and then say, oh, well, it just doesn't matter anymore. He or she is on renal replacement therapy. Just ignore the blood pressure now, it doesn't matter. It's even more important now to make sure that an adequate renal perfusion pressure is maintained so that the kidneys have a chance to recover again and that patients are not committed and left with chronic kidney disease and premature end-stage renal failure. And the risk of end-stage renal failure is very, very high in critically ill patients who've had renal replacement therapy, even if they are temporarily recover again.
And we may inadvertently increase that risk by the things that we do every day.
Correct. Yeah. Or the things we don't do by just not monitoring and just not paying attention to them.
Indeed, I think that's probably one of the most important key take-home messages from this whole Congress and from this session, that whatever you do, there will be backsides, and you really need to keep an eye out for all the potential adverse effects of your treatment. Dieter, I know we've had a chat about this within the context of VV ECMO, and it's for those of us who don't normally work with these kinds of techniques, do you have a take-home message? What are the things that we need to look out for?
Well, in VV ECMO, oxygenation is mainly dependent on your extracorporeal blood flow together with your recirculation fraction. And there again, you want around 60% of your venous return or cardiac outputs to be captured into your ECMO circuit. So there, echo can also help you a little bit to assess your cardiac output, as we discussed already. Like thermodilution isn't really helpful in that. I think that echo is really helpful in ECMO-related troubleshooting, not only to visualize the cannulas and to troubleshoot to maximize your support, but also in the differentiation of shock, for example. And I think you should pay special attention to the right ventricle, of course, in severe ARDS patients who are supported by VV ECMO.
Indeed. I'm just checking here on the iPad to see if there are any questions from the audience, and there are not yet anyway. So I'll just encourage you to send in your questions if any of you have. So I just want to come back to this CVP issue, Xavier. I know that this is having a bit of a revamp, but it's actually an old issue. It's just that we've forgotten about the usefulness of CVP. We've all assumed that because we can't use CVP to monitor fluid responsiveness, that it's a completely useless variable, when in fact it's extremely useful and extremely informative. And CVP is easy to measure. Almost every patient in ICU has a central line. It's a high fidelity online measurement. Why are we not using it more?
It's not. I think that people do not know how to use it, and it's the main reason. By the way, there was a very good commentary by Daniel de Backer and Jean-Louis Vincent a few years ago in Critical Care. I think it was 10 good reasons for measuring CVP. I liked it a lot. Just give you an example. On the very initial phase, diagnosis, you have a patient with bilateral infiltrates at the chest X-ray and shock. You don't know anything about the patient. The diagnosis won't be the same if you know that CVP is 0 or if you know that it's 15. The patient is intubated with ARDS. On Monday, CVP is at 12 in intubated patients. That's very common. Then the next day, CVP increases to 25. You know that something has happened. It's a very reliable marker of right cardiac preload, and you do an echo to assess the right ventricle. So it's a very good way to assess the right cardiac preload, which is, of course, a very important physiological variable. You have a patient with this CVP at 25. Perhaps you should adapt your target of mean arterial pressure, because you know that for the renal perfusion, it's not the same if CVP is 25 or 12. So many good reasons for considering this forgotten and neglected hemodynamic variable that's been used for years and years. It is part of the sophisticated hemodynamic monitoring we need, definitely.
So for those of you at home, don't forget to look at your CVP. Okay, so I'll come back to you, Marlies. This is also a session on fluid management. Could you comment on the latest trials of balanced fluid resuscitation with balanced fluids versus normal saline? What's your take?
Very good question. Very good question. So renal outcomes have been the outcomes of many of these fluid trials. And people like me protecting the kidneys better. But the most recent large randomized controlled trials, so the basics trials and the plus trials, have shown no difference in the development of acute kidney injury between those who received saline and or balanced solutions. And I think the key difference here is, in comparison to, for instance, analyses of large databases, that in these two trials, patients received far less fluid. So my take-home message is, if a patient needs fluids and their chloride level is not high, and they need a reasonably small amount of fluid, it probably doesn't matter whether you use a buffered solution, a balanced solution, or saline. But in those whose chloride is already high, or those who need large amounts of fluids, or have already received some fluids and just need more, then I would move away from the extra saline, because there is a risk the chloride goes too high and will then upset the glomerular function. So the choice of fluid to protect kidney function, in my opinion, it depends on what you're trying to do, how much fluid you're planning to give, and how much fluid has already been received. And I think that's really what we've learned from these large trials, and that's why I'm grateful they were all conducted. We've learned from them. We just need to interpret them now and apply them individually to the patient in front of us.
That's an important point. The question is, do we know how much fluids have been administered to patients? And I don't mean just in the initial resuscitation period, because we generally know how many liters of or how many bags of fluids we put in the first 24 hours, but it's afterwards. And I don't mean just, the fluids that we give in response to a fluid responsiveness test, for example, but everything else, our medications, our sedative agents, they account for a large volume of fluids that we infuse over time.
Absolutely right. But I put it to you, maybe it doesn't matter. What matters much more is whether you can assess the intravascular state of the patient. So whether they've received 5 liters or 1 liter is important to know, but it's much more relevant to say, is the patient, is he or she okay now? Is he after 5 liters? They may now be euvolemic, in which case the 5 liters were absolutely fine at the correct volume. They may be euvolemic after just 1 liter, or they may still be hypovolemic despite the fact that they had 4 liters. And I think that's where we need more training, more education, also probably more tools to help us assessing intravascular volume status better. So the person who's had 4 liter may just still need more. And the person who comes in and has that non-fluid, they may already be overloaded despite 10 mils.
I think this is where we need Xavier.
Indeed, I'm very happy with your message that we should adapt, in fact, depending on the patient's need. Then there are some patients where we know that we will give a lot of fluid. Patients that are deeply hypovolemic. I mean patients with intra-abdominal sepsis, for instance. We know we will give much more fluid than during pneumonia. And so do you think that in these patients we expect to give 5-6 liters in the first day? We may choose this balanced solution. We also have some data in diabetic ketoacidosis as well, where patients need more fluid. And you know that much better than me, but there are some studies showing a faster resolution of ketoacidosis with balanced solutions.
I agree with that. So if I expect to give lots of liters of fluid, then I would minimize saline or even avoid it. Then I would go for the balanced solutions. I'm perfectly happy to give 1 or 2 liters of saline, but I wouldn't give more. If large volumes are required, I think the evidence based on what we've got suggests that buffered solutions or balanced solutions are more kidney protective.
Okay. Thanks, Marlies and Xavier, for that. I think our audience would appreciate more hours on exactly this discussion, but I just want to turn to you, Dieter. What's your take on the balanced salt solutions within the context of VV ECMO? Does it have a place? Or?
Yeah, of course, it's crucially important to give as less fluids as possible in a patient with severe ARDS. I mainly give balanced fluids.
In your country, I think that you don't use saline for decades. In France, it's the opposite. Saline is still the major fluid that is infused. And when we speak to German or colleagues from many other Northern Europe countries, they say, okay, but you're crazy to give saline, still saline. Ringa lactate is definitely the first fluid chosen in many countries, not in France.
Oh, that's fascinating. I had no idea that normal saline was the go-to fluid. And in the UK, Marlies?
I think overall balanced solutions are first-line fluid in I think most hospitals, as far as I can say. I'm not. Certainly from when I speak to colleagues, my impression is buffered solutions are the first-line fluid.
Okay. Xavier?
Can I have a question? Then, okay, I will change my mind, and in the patients that will receive a lot of fluid, I will give a balanced solution. Then which one should I choose? The Ringa lactate is good, or should I choose plasmalide because it is more physiological, or you think it matters or not?
I don't think it matters. I think what matters much more is that you have an understanding of the fluid you're giving, that you know the electrolyte composition, that you have an idea of, roughly an idea of the pH, and that you can foresee what is likely to happen. And I think that matters much, much more than giving one or the other type of fluid. Again, knowing what you give plus monitoring. So if you give plasma light, which contains potassium, for instance, that's fine. Just keep a check on the potassium, because some patients may become a little bit hyperkalemic, and so forth.
Dieter, do you agree?
Yes, definitely. But if I may have a question for Marlies as well. So now if you go to the deresuscitation phase and you have a patient with a lot of edema, but you think that you do an echo, the vena cava is not too big, so how do you address that from a kidney perspective? Do you give diuretics? Do you give colloids to capture the fluid into the circulation? What's your perspective on that?
So it's a very good, such an important question. Again, through these trials, we've learned that the kidneys are very vulnerable to fluid overload. And the kidneys and the brain are hampered are limited in their ability to expand and swell. So unlike, for instance, the liver, when patients are fluid overloaded, intravascularly fluid overloaded, the kidneys will also become overloaded, and then the tight capsule prevents the kidneys from expanding. And this then leads to intrarenal congestion, intrarenal compartment syndrome even, which can be nephrotoxic on its own. And that's why it's so important. So decongestion or deresuscitation is not only important for the lungs or the heart, it's of crucial importance to the kidneys too. But now to your question, how would I do this? If I really thought the kidneys, the patient was fluid overloaded and potentially the kidneys were congested, then I would decide between the two methods which I've got. One is pharmacological, diuretics. The other one is extracorporeal fluid removal. I would go with diuretics first if I thought it was like the patient was likely to respond. So if they had preserved kidney function, if I thought the diuretics were being delivered to the kidneys, I would always try diuretics first. And then if it wasn't successful, I would go to an extracorporeal method.
And how aggressive are you in your diuretic use? Because I'm a cardiologist, we sometimes use total nephron blockage, like 4 diuretics. Is that something that you can advocate, or is that something you're against? Or?
The choice of diuretics, so the individual choice, the combination, and the doses depend on the likelihood of response. So if you've got patients with pre-existing chronic kidney disease, and we see obviously more and more of them, they will need higher doses or combinations. Combining diuretics has the advantage that you may be able to reduce the doses a bit and reduce the side effects. But it's quite a complex management strategies, which really depends on the pre-existing comorbidities, the likelihood of the diuretics to work, your experience, and also the state of the patient, i.e. how quickly do you need to see a response. If you haven't got if you have got plenty of time, and the patient won't come to harm from being congested for a little bit longer, then you can escalate your doses. But if you need to act rapidly because the patient will come to harm, then you need something that works quickly. And I don't think there's a recipe for one patient, which fits every patient.
Thanks, Marlies. That was a really, really good practical tip for me too. So we've got 2 minutes left. I'd just like to round off this session because it's been a huge session, hasn't it? I had trouble combining VV or ECMO with renal replacement therapy with fluid management and hemodynamic monitoring, but you've done extremely well. Now, I've benefited enormously just from this 45 minutes. Could have talked all day. So 30-second elevator pitch from each of you. What's your most important take-home message for today?
Monitor. Not only cardiac output with sophisticated devices, but also arterial pressure, CVP, as we said. Monitor and looks at what happens to your patients, your sick patients, your very sick patients. You should really see what happens to them and not leave the room without knowing the effects of your treatments and the evolution of the patient.
So monitor, act, reevaluate.
Not only with the sophisticated and expensive devices, we have many other means to do so. Sometimes non-invasive devices are appropriate. Arterial pressure costs almost nothing, CVP the same. So, but and lactate and SVO2, but it's not only with those sophisticated, expensive devices. Look at what happens to your patients.
Thank you, Xavier. Marlies.
I concur with that, and I would like to add also monitor the health of the kidneys when you do your cardiac output and your blood pressure and your CVP, and continue to do this even if kidneys have failed completely and the patient is on renal replacement therapy, because this may be an opportunity to determine whether the patient remains long-term dialysis dependent or whether they regain some kidney function and stay off dialysis.
Thank you, Marlies. And Dieter.
I would like to add that, yeah, of course, hemodynamic monitoring is important in our ECMO patients, but be aware that a lot of the devices we use are invalid, and assess our hemodynamic monitoring devices with a good understanding of the physiology of the interaction between patient and ECMO device. I think echocardiography is crucial in monitoring ECMO patients.
Right. Well, thank you, Dieter. And to our audience, thank you for joining us today. I hope you got as much out of this session as I did. To our experts, Professor Monet, Professor Osterman, and Professor Dow, thank you so much for your contribution today and for this really lovely discussion. I could have spoken for hours just listening to you and getting your pearls of wisdom. Thank you very much for spending time with us today.
Thank you. I also learned new things.
Me too.
Thank
Thank
you.
you very much.
Every day is a school day.
Every day is a school day.
Hello from Lives 40 in Madrid. We are live from the TV studio in the Congress. I am Maurizio Cecconi. I'm the president of the European Society of Intensive Care Medicine. It's really buzzing here. We have a great atmosphere, and I am very excited to chair this session on the groundbreaking release of some research with the editors of our journals, Nicole Uferman, the editor-in-chief of ICMX from Amsterdam, and Giuseppe Citerio, the editor-in-chief of Intensive Care Medicine from Monza. Hello both.
Hi, Mauricio. Hi.
How are you doing?
Very well in Madrid. Finally, we are back to a real Congress of European Society. Everyone is excited to be here. And I think everyone will be excited today to see this press release of two papers, one in the morning, one in the afternoon.
Yeah, I am very excited. It's really great to see people and to meet people, to have coffee together. You may even hear a little bit of noise, actually, from everyone that is around here. And I have to say, I would like to praise the editors, their team, and the journals of the society, because especially in the last 2 years and a half, where we could not meet, having journals disseminating information and knowledge at record speed, it's been a fantastic service for our community. So thank you both, and thank you for what you're doing. And maybe just before we start, can you tell us a little bit, Nicole, what's the main focus of ICM Experimental, just to remind people at home how they can access, maybe be an author on your journal?
Yeah, sure, Mauricio. Thanks for the opportunity. I'd like to remind all listeners that the aims and scope of ICM Experimental has broadened up to include all aspects of translational science. So not only what is happening on the bench, but all the steps from bench to bedside. So these kinds of studies, they fit the aims and scopes of ICM Experimental.
Thanks, Nicole. And Giuseppe, how has ICM changed over the years? Now it's one of the journals, maybe the journal with the highest impact factor if we look just at the field of critical care medicine. How can I succeed in publishing in ICM?
First of all, you need to submit a paper. So we agree inside the executive, inside the board, to be fast enough to give to the author an answer. I know that everyone to be published, but we have strict criteria, and I think people like Adrian today that succeeded in publishing intensive care is happy to be on the Journal of the Society. And I'm very happy to say that the journal became the reference point for the community, and we want to remain the reference point for the intensive care community worldwide, not only Europe.
Thanks, Giuseppe. Do you want to introduce the speaker and the author of the paper that is released during the Congress?
Thank you, Maurizio, and it's a pleasure to introduce Adrien Bouget. He's going to discuss today a randomized control trial that has been run in France. The idiapazone study is a comparison between 8 versus 15 days on antibiotic therapy for Pseudomonas aeruginosa VAP in adults. And I think we started as journal to publish randomized control trial. We will present 2 today, but during the year we have many of them. And I think the speed we are guaranteed to the author is the reason why many randomized control trial comes to our journal. I would like to leave the floor to Adrian. Adrian, are you ready?
Yes.
Perfect. You can present the result of your study to the community, and I would like to anticipate that the paper is already online on the website of the society as press release and will be on the journal in the next few hours. Please, Adrian.
Thank you. Thanks a lot. Hello, everybody. Good morning. Unfortunately, I'm in Paris today, but it's my great pleasure to present to you this randomized control trial that we conducted in France. And we have the pleasure that the paper was accepted in the ECM. So it's a very, very good pleasure for me to present this paper. So I have no conflict of interest in relation with the presentation today. And we will speak about Pseudomonas aeruginosa and more specifically Pseudomonas aeruginosa ventilator-associated pneumonia. You know that this is the most frequently isolated gram-negative bacillus in the ICU and the most frequently isolated bacteria in the airway. Pseudomonas aeruginosa ventilator-associated pneumonia is associated with a high mortality rate between 40 and 70%, and this is really for the clinician at bedside, therapeutic change the recurrence rate of about around 30%. So a few epidemiologic data before presenting you the results of our trial. This is a Canadian RCT, and in this study, the prevalence of pseudomonas aeruginosa was about 30–40%, and the risk factor to develop Pseudomonas aeruginosa ventilator-associated pneumonia were the duration of ICU stay and of hospital stay before the occurrence of the pneumonia. And for this specific type of pneumonia, the adequate empirical antibiotic therapy was only of 68%. This is a very nice study that was published in the Blue Journals a few years ago about treatment failure for Pseudomonas aeruginosa ventilator-associated pneumonia. This is from the French multi-center outcome area database. Approximately 400 episodes of PAVAP. And as you can see, the treatment failure defined as a death or the pneumonia recurrence occurred in approximately 1/3 of the patient, 112 patients in this cohort. The risk factor for treatment failure were related to the patient, the age, the severity, a limitation of life support, the severity of the patient, the bacteremia, and the previous use of fluoroquinolones before the first episode. So when we talk about the duration of antibiotic therapy, we have to cite this very, very important paper that was published by Jean Chastre and de Jama in 2003, more than 20 years ago. It was about 400 patients, all pathogens pneumonia, randomized in a short duration group, 8 days, and a 15 duration group, the long duration group. As you know, there was no difference for mortality or recurrence in the cohort, but for non-fermenting gram-negative pathogens, the authors observed more recurrence in the 8-day group, and the difference was significant. But in the secondary analysis that was published a few years later, the predictors of ventilator-associated pneumonia recurrence were the severity of the patient, is illustrated with the stage 2, the microbiology and the identification of a non-fermenting gram-negative pathogen or Staphylococcus aureus. But as you can see in the multivariate analysis, for 28-day mortality, the duration of antibiotic therapy in the secondary analysis was not associated with recurrence or mortality. So we designed this study, a randomized E-diapason study, a randomized control trial comparing 8 days of antibiotic therapy and 15 days of antibiotic therapy, specifically for Pseudomonas aeruginosa ventilator-associated pneumonia. The primary outcome was a composite endpoint combining 19-day mortality and recurrence, and we have been particularly attentive to the definition of the recurrence. Recurrence was defined as a clinical suspicion of VAP associated with a positive conceptual culture of a respiratory sample, and it has to be evaluated by 2 independent experts in a post-hoc analysis. The inclusion criteria were clinical suspicion, classically defined as 2 criteria, including fever, leukocytosis, or leukopenia, purulent rectobronchial secretions, and has to be confirmed with a positive quantitative culture of a respiratory sample, a bronchoalveolar lavage, plug telescopic SSR, or endotracheal aspirate. Patients were not eligible if they were pregnant, immunosuppressed, or if they received antibiotic therapy active on Pseudomonas aeruginosa, or if they were colonized and chronically colonized with Pseudomonas aeruginosa. So this was a non-inferiority trial, and we have to include 600 patients to demonstrate the non-inferiority for the composite primary endpoint that combining, as I said, recurrence and mortality at 90 days. 30 centers distributed throughout France actively participated. They were balanced between Paris and the rest of the country. And here are the baseline characteristics. As you can see, we encountered difficulties to include patients, and finally, we only include approximately 200 patients. The two groups were well balanced. The main diagnosis of admission was sepsis. The main reason for ICU admission were medical or urgent surgery. The patients were pretty severe, as illustrated by the SOFA score at inclusion or the proportion of patients needing catecholamines, more than 50% in the two groups. This is the main result of the study. This figure presents you as a composite endpoint, the primary outcome. That is a combining composite endpoint, combining mortality and PAVP recurrence. As you can see, for the short duration group, 25. For the long duration group, 35% of the patient reach this composite endpoint, and in the short duration group, 35.2% of the patient reach the primary endpoint. So the non-inferiority of the short duration group was not demonstrated for the primary endpoint. If we go further in details, there was no difference for mortality at 19 days between the two groups. The two groups were comparable, no significant difference for this endpoint. But there was a trend toward a higher proportion of recurrence. As you can see, it's 17% versus 9%. And we performed a Feynman Gray model, as illustrated with this figure, that showed a higher risk of recurrence of Pseudomonas aeruginosa ventilator CT pneumonia in the short duration group compared to the 15-day duration group. Concerning the secondary endpoints, the two groups had a similar median of mechanical ventilation, of ICU stay, of number of extrapulmonary infection, and acquisition of MDR pathogen during ICU stay. And of course, as expected, the median exposure to antibiotics was higher in the 15-day group compared to the 8-day group, respectively, as you can see, 23 days versus 18 days. So this is the first, to our knowledge, RCT comparing 8 days of antibiotic therapy and 15 days of antibiotic therapy specifically for Pseudomonas aeruginosa ventilator associated pneumonia. There was no difference for mortality between the two groups, but we observed more recurrence of Pseudomonas aeruginosa ventilator pneumonia in the 8-day group. However, the two groups have a similar duration of mechanical ventilation and similar duration of ICU stay. Unfortunately, the lack of power limits the interpretation of the study. Thank you for your attention, and I'm ready to answer for the questions.
Thank you very much, and congratulations, Adrien, for your study and for the publication. Very important study, some interesting, maybe surprising somehow results, I would say. I remind everyone that we can get questions also from online, so we are monitoring the chat. We already start to receive some. Feel free, and we will try to ask these questions to the people here in the studio and to Adrien. Maybe I'm going to start by asking Giuseppe, what are the strengths? Why did you decide that this paper deserved to be published in intensive care medicine? And what will be the weakest parts that you helped to sort out with the author?
Okay, as Adrian knows, we discussed this paper internally, and I think the most important point is the clinical relevance of the information, because we discuss daily on the duration antibiotic therapies in our unit. So we try to address an important clinical question. So the first point we take a look when we evaluate a paper is the importance for the clinician bedside of the question that the author started to explore. And in this case, the duration of the antibiotic therapy have a lot of consequences on cost, resistance of bacteria, and so we decide to go further in this direction to analyze this paper. This paper, as presented, didn't reach the aim that the authors were aiming at the beginning, and they stopped earlier the treatment. I would like to also to have from Adrian a comment on this, because I think that an early stop trial give us the, let's say, uncertainty as he presented about the result, but also bring us some new information, the information of VAPA recurrency, the no difference in mortality. And I think I would like to ask Adrian about his experience about the peer review of the journal and what he learned from this trial, because I think the readership could learn, could have some information, but also the author and the network learn a lot doing a trial. Adrian, I would like to ask you your experience with the journal, and the second point is what you can, if you start again today, what can you fix and what are the weaknesses you saw, and how can you solve for the future? And probably if you have any hints about, you say already that we cannot bring the information bedside today, but what will be the next step?
Yes, thank you. Thank you for the opportunity to respond to these questions. So for the first question about the journal, I have to say that this is a very pleasant experience first to be accepted in this journal as a critical care physician. This is clearly the reference today for our community, and it's a very great pleasure to have been accepted in the journal. And I have to say that the delays for the answer are very quick, and the interaction with the editorial board and the journal was very, very pleasant. So it was a very, very good experience throughout the process of publication in the journal. For the weakness of the study, it was, as you can imagine, very difficult to process the study. We only include 200 patients, and we have to include 600 patients. And despite the participation of more than 30 centers throughout France, the inclusion rate was very low in the different centers. I thought a lot about that since the end of the study. So maybe the criteria for non-inclusion were too important, and particularly immunosuppression. A lot of patients in the ICU, and particularly when they present infectious complications, are actually immunosuppressed. And if we decide to not include this patient, it's very difficult to perform a study. The second point is that, as you saw, as duration of ICU stay or mechanical ventilation duration before the inclusion was between 11 and 14 days. And at this point, many patients are still included in a control trial. And so we cannot include this patient in a secondary trial anymore. In my opinion, there are the two main reasons for the difficulties that we encountered in the realization of this trial. For the future, it will be difficult, in my opinion, to perform a large RCT about pneumonia for Pseudomonas aeruginosa or non-fermenting gram-negative pathogens. It was difficult to conduct the study, and maybe we have to perform some study more focused on other way to decrease the duration of antibiotic therapy, maybe again about PCT or some other biomarkers. But this type of study, in my opinion, is difficult to conduct, and it will be difficult to conduct in the future.
Thank you, Adrian. Nicole, maybe you want to ask a question?
Yes, also congratulations from my side for a very well-conducted study on a very relevant problem with this difficult to control infection, this Pseudomonas. So about the duration, there seems to be really a trend to the benefit of a longer duration. And even if you didn't find an effect on the primary outcome, what would be your idea of the use of biomarkers as an intermediate endpoint? Did you take any blood samples, perhaps, in which you could measure these? And if yes, what would be your idea? Which biomarkers, PCT or CRP or otherwise?
No, we did not perform some blood samples. We don't have a biobank to perform a secondary analysis about the use of biomarkers in the study. Yeah, for example, PCT could be interesting. it could be a possibility to decrease the duration of antibiotic therapy. But there is a trend clearly to few recurrence when you decide to use a long duration of antibiotic therapy. But there is no difference for mechanical ventilation duration or ICU stay duration. So what is the consequence of this pneumonia recurrence? It's difficult for me to answer this question. It's very something bad to have a pneumonia recurrence? Probably yes, but on what criteria? I don't know exactly today.
Adrian, we have some questions coming. I think it's also related to what Nicole just said. Were you surprised to find there is almost a signal of harm for a shorter duration of antibiotics, which is actually, it's a bit in contra tendency with what we are seeing in the literature recently. And then a second question, I didn't understand well the Kaplan-Meier plot. It was not significant, but are you planning to see a longer follow-up for this patient to see whether maybe there is separation of those curves?
No, I was not very surprised because when you look at publications specifically dedicated on non-fermenting gram-negative pathogen, there was a constant trend with more recurrence with short duration therapy. I don't know what is the consequence of this increased rate of pneumonia recurrence, but clearly I'm sure that when you decide to reduce the duration of antibiotic therapy, you increase the rate of recurrence. I don't know if it's a bad event or not, but clearly for me, there is more recurrence when you decrease the duration of antibiotic therapy. And I have to say that we did not include immunosuppressed patients. So maybe it's not very severe when you are not immunosuppressed, and that's because maybe that's why we did not demonstrate an increase of mortality or of mechanical ventilation, but maybe if we decided to include immunosuppressed patients, the results won't be the same. For the Kaplan-Meier, no, the analysis performed for 90 days. The difference is not significant, but we did not demonstrate it as a non-inferiority, considering the upper bound of the 19% confidence interval of the difference. That's why the non-inferiority was not demonstrated.
Another question, maybe from Giuseppe, or comment?
No, but my comment is that usually we are looking for papers that are changing our practice, and this paper probably will not change our practice. So I think that what you say at the early beginning, that the interaction with the journal was very productive. Talking about the journal, what about your experience? Because I think we need to tell to the community that the journal is able in less than 10 days to give an answer to the author that want to have an answer soon. Usually the answer help to improve a paper, and I would like to spread to the community your experience, because I think the trial is there, we can read it, we already highlight the pro and cons of the trial and the difficulties also.
But Giuseppe, the paper is already accepted, so you can be very honest, yeah. Adrian.
For sure.
No, honestly, the experience was pretty good. The possibility to have an answer in 10 days, of course, is something very helpful. We can have some doubts before submitting to intensive care medicine, but we know that this is very difficult to have an article to be accepted. And I would say to our community that we don't have to be self-limited. I think it's possible to submit an article. You will have a response very soon, and if unfortunately the response of the editor is not favorable, you will have learned something, and maybe it will help you to have your article accepted in another review. But clearly, the experience was very pleasant.
Nicole, can I ask you, in ICMX, what type of secondary analysis from a study like this would you like to see submitted?
Well, my idea would be that if you perform a meta-analysis combining all the studies with recurrence rate as an outcome measure, you will find a difference, and that may change practice or maybe. So I think this would be a valuable sub-analysis to do. And another thing would be, as you suggest yourself, Dr. Bouget, to look at the post-hoc analysis of all the clinical characteristics of the groups and compare these. And these would be very helpful to gain more insight in all of your efforts.
Are you planning any of this, Adrien?
Yes, we are thinking about meta-analysis, of course, because there are few studies about this specific topic in reality, and specifically for non-fermenting gram-negative bacteria. So we think that our results can be very helpful in the meta-analysis to demonstrate maybe that a short duration therapy is associated with more recurrence for non-fermenting gram-negative pathogens.
Okay, we have time for one last question. I'm always interested on the practical implications for the investigators in their practice. I mean, the signal is that it should be the longer duration of antibiotics, but is there any patient in which, in your practice, you are considering a shorter duration of antibiotics, and how?
Yeah, in my unit, for a patient that is not immunosuppressed, and we will present Pseudomonas aeruginosa, non-fermenting gram-negative pathogen pneumonia. We will use a short duration therapy, and that's what we learn to our residents, for example, that we have to use monotherapy and short duration therapy for pneumonia and for all pathogens pneumonia. But in case of a recurrence or for some specific patients, like immunosuppressed patients, I have to admit that we will use more longer duration of antibiotic therapy, maybe 10 days or even 14 days for some patients.
Thank you, Adrien. I think we are coming to the end of the session. I would like to ask Giuseppe Nicole to make maybe one last comment, but let me also congratulate you again. Fantastic presentation, great answers to the questions today. And maybe Giuseppe?
No, thank you very much for presenting your result and for highlighting also the weakness of the study, and I'm happy to see this manuscript on ICM, and I'm happy that the author also is happy to succeed in publishing intensive care medicine. Thank you, Adrian.
Thanks a lot. Thank you.
Dr. Boulet, I really think that there are only strengths to your study, including the thorough analysis of the definition of infection. And the only thing is the slow recruitment, but I think you did to the best of your abilities, and I think it's really wonderful that you concluded to this. So thank you for your great efforts and scientific work.
So thank you. And again, congratulations. Fantastic to have this first groundbreaking release here in Madrid. And I would like to thank again Nicole Ufermans and Giuseppe Citerio. And see you later on for another paper.
Thank you. See you.
Hello, everybody. I'm very, very glad to be here today in live discussion with Professor Comporata from London and Professor Pesanti from Milan. And we will be talking about their favorite topics, of course. And I want to begin with Professor Comporata about of course, the ventilator lung injury, induced ventilator lung injury. And I want to ask you in a few words, how can we personalize ventilation in order to prevent such a complication for patients who are under mechanical ventilation?
Well, thank you very much, and hi everyone. Absolutely. I mean, this is the main issue, isn't it? How to personalize ventilation. And one of the things we discussed yesterday was how we move from a recipe that can be applied to everyone. Instead, we look at lung mechanics. We understand a little bit more about some of the determinant of ventilator-induced lung injury, which is essentially the strain of the lung, the inhomogeneity of the lung, and try to address that. So how do we do it? I mean, one of the central concepts has been the concept of driving pressure as a way of normalizing tidal volume to the functional residual capacity, which is the strain. And the other issue is this concept of mechanical power, which is essentially a way of taking all the elements of mechanical ventilation, a bit like a recipe for a nice dish. We take the ingredient of this respiratory rate, the PEEP, the tidal volume, and we'll just create one single element, which is a mechanical power, which is the total energy to the lung. And I think that will give us an idea how much of that lung can be exposed and potentially injured as a consequence of that. So, yeah, it's a little bit more complex, but I think we start with a tidal volume that is appropriate to the lung using the driving pressure as a measure. That's a good starting point.
Okay. And yesterday in your talk also you talked about how to assess this ventilation lung injury induced ventilation induced lung injury, and I want to ask you how, in a practical way and at the bedside, how can we assess this and to alert clinician so that they can optimize setting of the ventilator in order to prevent more complication?
I mean, that I think one of the points of the presentation was how difficult it is to do that in real life. And because we said there are many components. There are the anatomical components that we normally look via CT scan or some of the radiological measures. There are gas exchange components, there is lung mechanics. And I think the combination of everything is what will give us a complete assessment. So we normally start with something like lung mechanics, and then we'll go to the gas exchange. But all the three things cannot be seen independently, but they need to be looked at together. And one of the points was also the importance of hemodynamics, so the perfusion element of gas exchange, which might be always a little bit neglected. And COVID-19 reminded us of the importance of lung perfusion in gas exchange.
Okay, thank you. And I would now turn to Professor Pesanti about his nice presentation of the self-inflicted lung injury. And can you, in few words, define this new concept, anyway?
Well, the concept of patient self-inflicted lung injury, whose acronym is PSILI, is a very, very ugly word, but what it means is that the patient might contribute to damaging his own lungs. And that is because we keep talking about ventilator-induced lung injury, while the correct denomination should probably be ventilation-induced lung injury. That is not so much what generates the damage, but is the concept of damage. And we know that the damage to the lung comes from tidal volume, pressures, decreased FRC, driving pressure. I mean, all the things that Luigi just said. All these could be generated by the patient himself, because the patient has a big engine, which are the muscles to breathe. So the respiratory muscles normally generate the power that in paralyzed patients is generated by the ventilator. But actually, it makes no difference. Luckily enough, at a certain point, the patient gets tired, while the ventilator normally does not. So sometimes we have to consider that in spite of the fact, which is the truth, that the best way to ventilate is spontaneously, like me and Luigi and you and everybody. We breathe very well spontaneously. If somebody gets sick at a certain point, it is more convenient to go to a mechanical ventilator rather than let the patient struggle to maintain ventilation. Because in this struggle, he might damage himself.
And so my other question will be, as a naive person, as a naive participant, how can we diagnose? If we have, for example, a patient, COVID-19, is coming in our unit, and he's still, not having all the indications to be intubated. And at what time we will say, no, it is probably better to put it under mechanical ventilation because he's developing the spontaneous lung inflicted injury?
This is a question that does not have a simple answer. First of all, there is clinical evaluation, use of the accessory muscles, dilatation of the nostrils, respiratory rate, inspiratory effort. In kids, you can see the space between the ribs to get depressed. But this is basically a clinical evaluation. And we have hints. As an example, if the patient has a central venous line, then the central venous pressure goes down during inspiration. That is normal. How much it goes down is normally linked to the inspiratory effort. So that is one thing we can get an absolute number about. But basically, if in a non-instrumented patient, the most important things are clinical evaluation, respiratory rate, movement of synchronism of the movement of the chest, and central venous pressure, I guess. Did I forget something? Oh yes, activation of the expiratory muscles, sometimes involvement of the abdominal muscles, but all that is clinical observation. At that point, we might probably be taking some measurements. But clinically, what we do is to intubate the patient normally, or to get to an intermediate step, which is non-invasive support. At that point, we have additional measurements. We have measurements of the tidal volumes. We have normally blood gases, saturation, and that tells us a lot about what the patient is doing. As an example, if the patient has very high tidal volumes during non-invasive ventilation, that is an indication that is going to fail non-invasive and to need control mechanical ventilation or invasive mechanical ventilation.
Okay, and what do you think about patients who are under high flow oxygen? You know, with COVID-19, we used a lot of high flow oxygen in our units. And is it probably possible to have some information from electrical impedancemetry at the bedside? Do you think is useful as a tool at the bedside to detect this kind of injury?
It's certainly useful, most of the time practical. Point is that we have very few of those machines. So measuring objective tidal volumes in patients non-intubated, spontaneously breathing in high-flow nasal oxygen is not simple. There, I think clinical observation is the most important thing to do. And EIT can be used when you have some doubts.
Do you have any complementary comments about this?
Maybe two comments. One was the going back from the high flow to the PCILI. So there are some other scoring systems that perhaps we can use, like the ROX score, so which is the SpO2, FiO2, and takes into account the respiratory rate. Obviously, the validation outside COVID-19 will point to a cutoff range which might not be applicable to other conditions like COVID-19, but I think the trend over time might be very useful. If the ROX score improves, then it's an indication, together with everything else that Professor Pesenti already alluded to, that the patient is responding or at least not deteriorating. Whereas if everything else goes in the wrong direction, then is a indication, and I completely agree, that we need to take control, because one of the issues of spontaneous breathing is that we don't know. We just discussed now, we don't know what the inspiratory effort is going to be. We don't know what the pressures the patients are developing. So we have complete lack of monitoring. We are driving a car without sat-nav and without any instrumentation, and that's the time when we need to control. And now there are plenty of studies now demonstrating in adults, in children, that excessive effort increases lung edema. Increasing lung edema makes the elastance of the lung worse, and the effect on the respiratory effort is an amplification of that phenomenon, with a vicious cycle that leads to exhaustion. But in the meantime, it leads to further injury. And that's one of the way of interrupting that vicious cycle, is to control the breathing and the forces related to the breathing through controlled ventilation.
I think one of the most important points that Luigi brought up is the time evolution. We follow in time how the patient is doing. You know, sometimes the patient improves, sometimes it does not. And so it's not a picture. We shall have frame by frame follow-up of the patient to understand what he is doing. Is he improving or not? Are our therapy having effect or not? Because we must be very, very attentive to the evolution of the patient and intervene at the correct time.
Okay, and I have a question for both of you. Do we have any particularities for the COVID-19 patients? As we can imagine, there is a cytokine storm, and there is a big inflammatory phenomena in the lung. Is it increasing the incidence of such complication, either the ventilator lung injury or the PCILI? Is COVID-19 a factor to increase the incidence of such complication, do you think?
Well, I'm rather skeptic, because we've been hearing a lot of alarm about cytokine storm. And when we measured the level of cytokines, these were not, it was a breeze, a gentleman breeze. And most of the times. Sure, inflammation is very important in COVID-19, but I think from that point of view, it's nothing really exceptional from other ARD types of ARDS. COVID-19 has some peculiarities, has some aspects that are present in ARDS anyway, like vascular occlusion, vascular obstruction, intravascular thrombosis. In COVID-19 it's very common, most of the time it's amplified, but it's not something really specific. It's part of the picture of ARDS, which is really many diseases. ARDS is a syndrome, is a collection of symptoms, not a disease. And the thing that connects all these patients is the need for ventilatory support, really. So I don't think really that COVID-19 is something exceptional. It is a specific collection of things, but it's not very conceptually, it's part of the ARDS picture. But we have to keep in mind that what made COVID-19, or makes perhaps, because perhaps next winter we get it back, I don't know, I hope not. But what makes it different really is the very high number of patients that we had to accept in waves in the hospital. So the problem was not limited to the ICU. We had patients in the wards with non-invasive ventilation, with helmets, masks. So it was difficult. We had to design new ways to take care of those patients. That was what was really peculiar and challenging in COVID-19.
Yes, I mean, I fully agree. I mean, there are two components. There's the disease component and the pandemic component, that the two interact in terms of the treatment, that not necessarily what we thought was optimal, but what could be practically deliverable at the bedside. So that's one aspect. If we go back to the cytokine storm, I think I'm with Professor Pesenti on that. When we looked back, I mean, the literature is very clear that when we look at other pneumonia from other etiologies, such as viral etiology, H1N1, these patients were equally, if not more, inflamed than COVID-19. So we looked back in our database going back 12 years, and we looked at H1N1 patients, we looked at COVID first wave, second wave, and third wave. And the H1N1 patients were more inflamed, had more CRP rise, had more procalcitonin rise. There was more bacterial co-infection leading to inflammation. And then we've seen that inflammation actually reducing over time. The first wave was almost the same as H1N1, and then slowly. So part of it was the co-intervention, obviously the vaccination, the early steroid use, a low dose. And the other one was obviously the changes in the variants. They're becoming a little bit more infectious in a way, but less virulent in terms of alveolar inflammation. So I think it's an evolving disease, and certainly cytokine storm is always impressive, but it's not what we've seen on the bedside. If I might add one more thing, but obviously it's relevant for what we are talking about. It's relevant to VILI and it's relevant to PCILI, because it's an inflamed lung, it's a lung that stimulates the brain to breathe. And breathing more in a dysregulated way is the common factor towards a ventilator-induced lung injury. So inflammation is important for what we are discussing here, which is the self-inflicted lung injury or the ventilator-induced lung injury.
Okay.
And if I may, the other important point of COVID-19 is that sometimes it takes weeks to heal. It's very slowly resolving sometimes. It might take 2 months to go back to normal, even more than 2 months. And that is probably the longest viral disease that I remember. I do not have a wide enough span of time, but H1N1 as an example was very quick. COVID-19 moves slower, and we need a lot of patience. Not a lot of patience, but a lot of patience to take care of patients.
Yeah, you're true. Yeah.
No, I agree. And actually, the length has only increased with the subsequent waves. And we have seen, particularly the more severe patients, for example, patients needing extracorporeal support, taking longer and longer to get better in the second and third wave compared to the first. Whether we are selecting a different population now, so they are not directly comparable. These are patients who have generally failed the treatment, and so there is a lot of interaction between their disease and the treatment, or whether it's a different pathology. It's very difficult to say, but certainly multifactorial, but the phenomenon is reproduced everywhere internationally, I think. I don't know your experience, but that's ours.
Yeah, you're right. And now let me ask you about prone positioning. And in this COVID-19 pandemic, we discovered, probably it's not very new, but we discovered the prone positioning in patients breathing spontaneously. And is it a way to prevent the PSILI? And after, I want also to have your opinion about the prone positioning for the VILI also.
I think prone positioning has been using widely in spontaneously breathing patients, and COVID-19 was one of the most important determinants of these enlargements of the indications. In theory, it should decrease the risk of ventilator-induced lung injury because the mechanisms acting in spontaneous breathing are approximately the same that act in controlled mechanical ventilation. Sorry, so if we believe that, and we know that prone positioning improves survival in severe ARDS, then we should expect it to decrease ventilator-induced lung injury in spontaneously breathing patients too. There is some problem with sedation, positioning, tolerance. It varies a lot from patient to patient, but we've seen a lot of awake, unsedated, or very lightly sedated patients in spontaneously breathing or in non-invasive, helmet non-invasive ventilation, tolerating pretty well proning. So it was a good surprise to us that it was possible to do that.
And we have data also from a large study, French large study about the.
Sorry?
We have data also about the prone positioning in spontaneously breathing patients. Now new data.
There are published data on the positive effect of it. Not randomized trial, I guess, but there are a lot of experiences reported.
Yeah, there is only one meta-randomized control trial, the one in Lancet. Yes. So going back to the, you were saying about the VILI, the ventilated patients, ventilated patients, clearly is effective. We know from the Procedure study that it's effective in ARDS. We have now several studies showing that the same magnitude of effect in the patients with COVID-19. We've published a study comparing ARDS with COVID ARDS internationally, and is exactly the same magnitude of effect. And the determinant of success is essentially similar. What is interesting is the timing. The earlier, the better, and this is true also with ARDS. It makes sense because at the beginning we've got a lung that is more prone to recruitment, there's more atelectasis, less consolidation, dense consolidation, and that changes over time. So the key component is the response in terms of gas exchange, CO2, PF ratio, and the earlier the better, so the responsiveness is better. And sort of some of the meta-analysis, even recent, including COVID-19, highlight that effect. So the earlier and the response are determinant of outcome. One of the things, if I can add, about the difference between spontaneously ventilated and mechanically ventilated is the diaphragm. Obviously, during spontaneously ventilation, most of the diaphragm action is about posterior inflation, which obviously when we prone a patient to spontaneously breathing, sometimes the mechanical effect is slightly less marked compared to the ventilated patients who is not moving the diaphragm, so it's passively ventilated, but the effect on perfusion might be slightly more. So maybe those are the differences which also explain why going from supine to prone, there's a huge difference in PF ratio, and then during resupination, you lose that PF effect most of the time.
You want to add something, Professor Pezzenti?
No, you know, Luigi is much more exhaustive than I am.
And Professor Comporota, yesterday you talked also about the hemodynamic effects of prone positioning. Can you say a few words for our audience?
Yes. I think one of the interesting elements, we know that ventilation and perfusion go together, and obviously vascular pressures are one of the determinants of lung injury because we need edema and to have lung injury. And so one of the things about prone positioning is that it can change the preload of the right ventricle. It can change pulmonary vascular resistance by just the physical phenomenon, by decreasing essentially the compressive forces on the vasculature. And if we increase the preload and decrease the right ventricular afterload, then we can see we can increase left ventricular preloading. And if there is preload dependency, then the cardiac index goes up. We've seen in some studies like the Procedure and some other French studies looking at physiology, how normalization of the right ventricle and improvement in cardiac index can be verified post-prone positioning. So there is an effect. At best is neutral, at worst is positive. Sorry, the other way around, but at worst is neutral, yeah.
Okay. Professor Pezzenti, if you have a final key messages you want to now to say to all the audience about the PSILI and COVID-19, what do you say?
My final message about PSILI and COVID-19 is that COVID-19 gave patient self-inflicted lung injury a chance to become very common because patients came in waves and ICU's beds were not enough to take care of all the patients. So we got a lot of patients in the wards in non-invasive ventilation, CPAP or pressure support. And so we had a huge number of those patients that before we were not used to see. And so our perception of the problem suddenly became very, very important. So it's something we have learned that will be useful in the future for all the patients.
Same key messages for you.
I think for me, the key message would be that we often think about one single magic number that we'll need to measure and target. And one of the things that we've learned, particularly in the last 2 years, is that there is no such a thing, and it's always a triangulation of many other measurements. And I think we need to think about measuring various aspects of mechanics, gas exchange, the vasculature, the hemodynamic, and only through understanding the interplay between all these components that we can optimize, we can call it personalize the ventilation. But looking for one single thing, there's been a lot of debate. Should we give 6 mils per kilo, 8 mils per kilo? Can we be more liberal? It's actually not really addressing the problem, that not everyone is the same at the same time. Patient day 1, day 3, day 7. So in summary, I would say let's try to have a multi-modal way of monitoring the patient and trying to understand in what phase of the disease they are, so we can optimize ventilation for that patient at that particular time.
Thank you. Thanks
Thank
a lot
you,
for
thank you.
this very interesting debate
you.
and really very pragmatic key points. Thanks a lot.
Very
Thank
grateful.
you.
Thank
Thank you.
Thank you.
911 emergency. First aid accident. 911 emergency. First to your left today. One emergency. First unit accident.
Good afternoon. My name is Daniel de Bakker. It's my pleasure to be with you for these interviews with three experts that presented this morning very attractive talks and debates. So we'll begin with Samir Jaber from Montpellier. You were one of the experts in the COVID-19 patient. Should we intubate these patients and when?
Thank you very much, Daniel, for this major question. Now, we learned a lot of something from these last years about how to intubate, when to intubate, and how to evaluate the severity. First of all, the main message is to monitor very clearly the patient as early as possible, as all patients with acute respiratory failure. This is mandatory. Second is your question is very important when. Obviously, the answer is probably each patient is different than the other, but we have some direction. First of all, the most severe patient should be intubated as early. This is very clear, and this is the same COVID or non-COVID-19. The second point is that probably we think that with the data that we have, it's probably the evolution of the status of the patient. We estimate that 1 hour after a full treatment therapy as maximum, what means full therapy, that probably when you use high flow oxygen therapy, you can use CPAP, you can use non-invasive ventilation, you can start as early as possible to put the patient in spontaneous breathing in prone position. Then when you have all this performed as soon as possible correctly, and you observe no improvement of the clinical variables, the gas exchange, and the status of the patient, then you can say this patient should be intubated. Then the message is not delay maximum 1 hour of this treatment as early stage. This is the second thing, and the last is probably you always should take into account the environment. Probably now we have a lot of data coming from different countries. Probably it's not the same in UK, in Italy, in Spain, in Europe, in Asia, in North America, in South Africa, and difference in America. So you should take in account your environment. How many nurse-patient ratio you have is probably not the same. How is your healthcare team? Do you have a very skilled physician for intubation? And how many physicians you have when you are on call? And this, you should take into account of this. And then the last question is when you have a patient which is borderline, which is in the gray zone. This is a major question that you have, all of us. The answer, as we always said, is now the personalized and individualized medicine. What means probably each patient different, but you can imagine that this patient in gray zone, you should take into account also of your skill of intubation procedure. It's not the same, and also please always consider the difficult intubation parameter of this patient. This is not very used in practice in ICU, in contrary to anesthesia. When you are in anesthesia, every patient is evaluated for the risk of difficult intubation during the intubation in OR. Or in ICU, it's not our practice every day. Then now I think we should change and take into account the difficulty of intubation. If you are 50-50 chaired by all the other physicians in your team, probably the answer is you should intubate.
This last aspect is something perhaps very important that was pointed out in the debate, because indeed you add to the usual difficulty of the patient for the morphological aspects for the intubation, and you add specific aspects related to the respiratory failure aspect, which is probably put to an extreme fashion when you use these helmets, CPAP or HFO. And in addition, one very important aspect is that you add another complexity, which is the safety for the personal procedures that you have also to respect. And sometimes these, with all the sweat and other things that blur a little bit the vision, make also the intubation more difficult. So how do you try to manage the combination of these? You mentioned, okay, you evaluate in advance the patient intubation difficulties. Another, you say also you monitor the patient. But what is exactly the monitoring aspect you use? Is it respiratory rate? Is it PO2? Is it saturation? Or what are these variables you take into account?
Thank you, Daniel, for this question. Is a major question. What parameters, what physiological variables, which are not the same things? Probably one of the best one is, I think, in my point of view, is the respiratory rate, because it's a very simple and it's a measured variable physiological. We have now data and publication about different scores, but the scores you should calculate. The ROC score is a very nice one, obviously, which should take into account the respiratory rate, the oxygen saturation, the flow of oxygen delivery, the air rate, everything is very interesting. But probably the major one is respiratory rate and the evolution. This, I think, is probably the main factor that you should take into account. It's not the same if you have a patient, we start at 35 cycles per minute, and 1 hour he's almost, or 40, or this patient probably should be intubated. If you have decrease of your respiratory rate, if you have an increase of your pulse oximeter saturation, if you have decrease of heart rate, if you have some physiological variable in the good sense, probably you should wait, or you should consider to continue non-invasive ventilatory support as high flow oxygen therapy, or something like non-invasive ventilation or CPAP. But if you would not observe any improvement, especially clinical improvement or blood arterial gas exchange or anything like this, hemodynamic status, probably you should intubate the patient. And please always consider the time when you've made this evaluation. It's not the same when you are at 10 o'clock in the morning or at the on call. It's not the same. How many physicians you should? Now we know that for the intubation procedure, 4 hands is better than 2 hands. 2 experts is better than one expert alone, and you should optimize the pre-oxygenation, etc., etc. But also consider the difficult intubation coming from the patient and the environment of the healthcare.
You mentioned the environment, but I think this morning you also emphasized quite a lot in the debate that this patient should have an adequate environment, meaning that even though we were sometimes forced to have patients under high flow or even sometimes CPAP in wards, not in the ICU, these patients should, as much as possible, be in the ICU. And when the severity is increasing, when the patients are really not responding initially to these support, they should be in the ICU for adequate monitoring, of course.
Absolutely right. You should monitor very early the more severe patient or the more patient at risk to decompensate. This is mandatory, as is possible you do everywhere, because now, as you know, all of us have some difficulties during the first, the second wave to have the bed, number of the bed is limited in every hospital or private clinic, it's the same. And this probably should the major point to have this evaluation very, very early, as you state. I think you absolutely right.
I think that Antoine Schneider wanted to ask you a question. Antoine Schneider is from Lausanne.
Thank you, Daniel. Yeah, in my center, for those patients we're not sure whether to intubate or not, we sometimes did a trial of non-invasive ventilation, mostly with CPAP, not really to ventilate the patient, but to have some form of measurement of the tidal volume that the patient were taking and to assess whether there was a risk of volume associated, induced lung injury. Is that something you would recommend or consider?
No, you're right. We discussed this morning that each patient is different. Probably you're right when you said a patient with 25 years old is not the same patient than 65 years old with 2 or 3 comorbidity. This is not the same. Then when we have the difficulty in our experience like you, when you have half of the patient want to intubate and the other one to intubate, you always said, oh, maybe we can give him a chance with a CPAP or an invasive ventilation or something like this. The acute respiratory failure of COVID is mainly hypoxemic. Then it's mean that it's the problem is the gas exchange, is the lung exchange problem. So when you have an hypoventilation and you start to have an hypercapnia, that you mean you have probably a pump failure start. That means probably change the status of the patient, and then in this patient probably it's not good to push too much the non-invasive ventilation. However, for the other, if you use oxygen therapy alone, high flow or not, if you use CPAP, because you can treat hypoxemia and prone position, maybe you can make a test, a trial to see it's okay or not, and wait, I don't know, 30 minutes, 1 hour. But probably too much delayed the intubation is not good. But you can every time start. But for the majority of our experience, each time when half of our physicians want to intubate and half don't want to intubate, the final decision is intubate, and the time gives us the answer.
But in follow-up with this question, and this was a little bit in line with what has been said this morning, what is the usefulness of the non-invasive ventilation to have some assessment of the tidal volume and hence the risk of stress and strain to the system? And so the second part is, how do we assess the contribution in terms of helping to decrease the strain by decreasing the respiratory muscle force, and perhaps in some cases we do not have this impact. So could you comment a little bit on that?
Yes, the question is a question which is available both in non-intubated patient and in intubated patient. It's the same. When you have the couple of patient and machine, both produce a certain level of work of breathing. We call total work of breathing. This total work of breathing is checked by part by the ventilator and part by the patients. So when you start, for example, for just an example, for 10 centimeter pressure support level delivered by the machine, and you need 20 centimeter of water, then the other 10 centimeter was performed by the patient. Then the total is shared 50-50%. Then you monitor at this moment the tidal volume delivered, the respiratory rate, which the product is the demand of the patient, what is the minute ventilation. This is the reflect of what needs the patient. So during the evolution, you have different possibility. If the patient increase his inspiratory effort to maintain the same tidal volume, that probably you start that we called more recently, we know very well these 5 last years, what is called is self-induced lung injury or self-induced diaphragm injury. Why? Because you make the patient make a very, very high effort, inspiratory effort, and now we have data that you induce not only in the lung injury, but also in the respiratory muscles, mainly in the diaphragm. So you should absolutely avoid this. So when you see the patients, the tidal volume decrease and the patient increase his respiratory rate, that probably is not good. Or then you increase the inspiratory pressure delivered by the ventilator, that it's probably is not a good patient. If you see for the same patient, the tidal volume increase, that probably you can decrease the pressure support level, that the level of assist of the machine. That means probably you could have an improvement of the patients, mainly for the respiratory muscles force. Then it's one indicator. That's why it's simple to see the respiratory rate, because it's the first one of the physiological modification that you have and the compensation. But the respect of the work of breathing, the partitioning, help you to stop or to continue.
So thank you very much. Obviously, still a very challenging aspect to decide whether or not we should intubate and when we have to intubate. There are many research questions that need to be addressed, and thank you for having covered this very nicely for our readers. Now we have to move to Carole Boulanger from London, UK, and this morning you had a very interesting breakfast with the audience discussing end-of-life decision practices. Could you summarize a little bit what you had this morning?
Of course, yes. So this morning we had breakfast with the experts. So 4 experts in end of life. Most of us teach on the ESICM masterclass for end of life. And the idea really came behind on the masterclass. There's been lots of questions about they'd like to actually sit and talk with people about particular issues that have happened in their units or things that they're challenged. So it was a bit like speed dating for end of life because time was short. So we moved around as experts, each with a broad topic that we introduced to the table of participants. So those topics were education in end of life and how we do or don't do that, and whether we actually need more of that. Discussions with families, difficult family discussions, and about shared decision making and how that can help. We were also talking about ICU as in palliation and shifting the goals of care from active management for a disease process to palliative care. And then the 4th topic was talking about how do we actually do it? How do we actually withdraw or withhold treatment, which is something that was interesting for all the participants. It's something that everybody does slightly differently, and people do find it really quite challenging. And the participants we had were from a wide range of countries, which meant that we had a broad experience from Colombia, Brazil, Australia, lots of European countries, and there was quite a lot of variation. So there was an awful lot of discussion and debate and sharing of information about and learning from each other about how we actually do this, all those aspects. And time disappeared very, very quickly, so we certainly ran out of time. And we as the experts really enjoyed those interactions with the participants, and it seemed that they did too, to enjoy and have the opportunity to be able to say, I've had this situation in my unit, how do you think we could do this better next time for the patients and families involved?
During that aspect, did you have perhaps the time or the chance to discuss the fact that during COVID-19 crisis, we had to face really different situations that before, just due to the surge and also the difficulties to link with families, at least in the first wave. So did you have the time to discuss this or not?
Certainly that came up in a couple of the sessions that I did, and we talked quite a bit about the differences about how in different countries we manage that. In the UK, we did quite a lot of family discussions over FaceTime, and that also sometimes was actually the point of withdrawal of care was over FaceTime if the relative was frail, unwell, unable to visit, although the visiting restrictions were altered at end of life. And that brought a lot of discussion about how do we have those conversations with families and sometimes with patients if they're awake when you're not in the same room and you can't get that feedback from the relative. You can't offer them any sort of physical comfort and they may be at home alone. So yes, there was quite a lot of discussion about how we developed very quickly across all of the ICUs in the countries that were represented ways to be able to have those conversations as effectively as we can. But also, many of us were having a lot more of those conversations because of the nature, particularly in the first wave, because of the nature of COVID. So I think there was a lot of learning from having to do things slightly differently in COVID, for sure.
And you mentioned also the point that you had participants from all over the world, and this is of course great, but this reflects also a little bit the patients in our ICUs. We have a multicultural societies, multi-religional societies. How do we address this in our hospitals? Because sometimes the doctors are more for the same culture, but treating patients from different cultures. So how do we deal with this difference in culture between doctors or nurses and the patients themselves?
I think that's it's a really good question, because I think we are seeing multicultural, and the question is, the answer we always give is ask the family, and try and involve if there are particular cultural or religious issues or real values for the patient and their family, then actually drawing those the support from those cultural or religious backgrounds into that really makes sure that we can individualize the way that we have those conversations and we manage care going forward, so that it doesn't feel like they feel like they're part of that process. But it's something we're all having to get much better at, in terms of asking families and then drawing in other experts to be able to support us in bringing the family and the patients along on that journey.
Okay, and how do you do this, let's say, in practice? This means that you do this you make a meeting with all these, you have this repeated. How do you, in practice, really do this kind of meetings and discussion of end of lives with your patients?
So yeah, if it is that there are real religious or cultural concerns, first ask the relatives. We'll often say these are my values, and they may differ from ours. And I think that's an important thing too, is that we have to recognize that when it comes to end of life, we bring our own values whether we like it or not. We have to be aware of that. And then actually, certainly what our practice would be to get engagement with somebody that they value in terms of the cultural or religious beliefs that they hold, and have them involved in the conversation. For sure, that can be tricky at times, but actually it makes a difference to how the patients and or particularly the families feel going forwards at end of life, because sometimes it's about feeling like it's permission to let go. So yes, communicating and drawing in those experts definitely helps to reduce some conflict, and it helps to make sure that relatives are not going away feeling that they haven't been heard and that their particular values have not been taken seriously.
These last years, we had seen a lot of trials ongoing in the field of end of life, and this is really great. What are, in your mind, the most important research questions that still need to be addressed in this domain of end of life procedures or perceptions?
I think there's a few things for me. I think there's some really nice research out there now about interprofessional decision making, and I think that possibly needs to go slightly further and bring in the other people who may have clear values for the patient and their family. So I think that that would be one. Certainly in terms of education, I think education is sometimes education around some of these difficult conversations and difficult times falls below some of the more physiological aspects of managing patients in ICU. So I think it would be nice to see more research on how we can do that better, how we can actually equip people better, because you have one shot to have those conversations effectively. You can't, with that family, you have one opportunity. And so I really do think that there's something in there about education. There's such a wide variety in practice about how we actually physically withdraw treatment, and it would be nice to see more research exploring why that is. And some of that will be exploring our own values about that process. So those would be the things that I would pick.
And you mentioned at some point that this morning you had some discussion on the ICU used for palliative care. How in practice this is done, and especially with regard of the shortage of beds on one hand, and perhaps also on the stress put to the healthcare personnel of the ICU, which is already under pressure, especially after the COVID area. So it's, could you a little bit summarize these kind of aspects?
So the ICU as a palliative area is it's not that new, but it's relatively new. But I think it's about switching the goal of care. And so it's about switching the goal to actually for palliation. And that feels difficult for clinicians because we want to be able to return all our patients to a previous form of life. In terms of logistics, it's not easy with limited beds. There may be a 20-year-old in emergency department who needs to come, and you've got a patient for whom the plan is to withdraw care. And for what we find in the UK, we're getting involved with the palliative care team, and they can be really helpful in facilitating beds at a hospice. We've recently taken patients home and withdrawn treatment at home. And so that has an impact on resource in terms of staffing, for sure, but actually bringing in those experts to say, okay, how can we do this better whilst making sure that we're carrying on with the day-to-day business of the unit. From a staff point of view, the nursing staff, particularly who've had that sort of 12 hours a day time with the patient and their family, being able to complete that episode of care with the patient dying peacefully and having a good death seems to be quite important in helping with avoiding burnout and stress. So being able to complete that cycle, whilst it can be stressful in itself, does seem to have quite a lot of value. So as ever, it's about balancing resources, but actually bringing in other teams who can maybe help with locations and support can often make a difference.
And regarding support for especially nurses, as you mentioned, who are indeed more at the bedside of the doctors, how do you manage the support for these nurses when indeed sometimes it's a little bit difficult to be on one day on the full support and very passionate on one aspect, and then okay, after some discussion with family, with the doctors, with whoever, well, we switch to more palliative care. And how, in your mind, you make this more easy? And what is the practice in your ICUs or whatever that you should promote to try to make this more easy for everybody to change from a full support to a palliative aspect?
I think what really helps is the communication with the clinicians, bringing the nurses along with the decision making, because often you'll find, I'm sure you find, that your nurses will say, what are we doing? Shouldn't we be making some decisions here? So I think the first thing is actually being involved in the decision making definitely helps the nursing teams feel like everybody is on the same page with what's going on with the patients. The issues with nurse staffing at the moment is we've all got units with very junior staff, with people who've not been in ICU very long, and that means that the emotional and moral burden can be really quite high. And so the support that we put in, we have a clinical psychologist who comes to the unit a couple of times a week purely for staff, and that's made a massive difference in these sorts of situations where there's an opportunity to discuss what has gone on, because you'd like to say, yes, you do that process alongside an experienced nurse who's going to be coaching you through. The reality is there aren't that many of them about, and there's other things that they need to be doing, not that this isn't important, but actually having that support network in place, certainly in our unit, has made a massive difference to sickness levels, to stress and to burnout. So there's something around having, whilst we haven't got the number of experienced nurses we'd like, it's about having that sort of wraparound support to make sure that we gently ease people through to make sure that they get the experience and the support that they need.
So thank you very much. And I think, as you mentioned, the communication is really one of the key aspects there, and it's very important to re-emphasize on that aspect indeed. Thank you very much, Carol. So we move to Antoine Schneider. Antoine Schneider is from Lausanne, and is a specialist in renal support, among other aspects. And so could you a little bit summarize what you had this morning? Your talk was indeed update on the literature there.
Yeah, thank you. Well, indeed, we discussed the new literature, not only in the area of renal replacement therapy, but acute kidney injury in general, AKI. Well, there's been lots of published trials. It's been quite hard to select the ones I was going to talk about in this 15 minutes talk. And it's even harder to summarize that in even shorter period of time. But I mean, basically, there's been a few trials that have, either going to change practice or changing our understanding and knowledge of AKI, and these are the ones that I selected finally. And also those that are really the major publication, the major large trials. I started with the PLUS trial, which is not exactly an AKI trial per se. It's a fluids trial. It's one of these huge N6 randomized control trial. They included more than 5,000 patients, and of course they were comparing plasmalite with saline, to me, this trial is important because fluids, although of course there's been so many fluid trials, and fluid is something we do on a day-to-day basis. It's something every single patient in ICU will get at some stage, whether the choice of fluid might change, maybe even 0.1% or 0.5% in terms of 90 days mortality. Well, that would be huge in terms of public health in general, because it's something that's so commonly performed. So this trial was trying to establish whether plasmalite or balanced solution would improve the outcome over normal or like not so normal saline. And it was a negative trial. The primary outcome was 90-day mortality, and of course, no. I mean, it failed to demonstrate a benefit. It also showed no benefit in terms of renal replacement therapy or incidence of acute kidney injury. But it adds to the knowledge, and there's been just published, I think, the same time, a meta-analysis integrating this data, and so there's more than 35,000 patients that have been randomized to this intervention, and we still don't know whether one is better than the other. The trend is really towards a benefit, despite the results of this PLUS trial, the most recent and one of the largest. The trend is towards more towards crystalloids, balanced crystalloids versus saline, but there's still no definite proof. So this controversy will continue. So that's one of the first trials I discussed. And then still in the fluid topic, I discussed the reverse AKI trial. And to me, it's an important trial as well. It's a much smaller, it's 100 patient, was a pilot study that was conducted by the AKI section group, where we try to evaluate whether a protocol aiming to decrease the amount of fluid administered in patient with acute kidney injury would be associated with harm, or at least potentially, or at least was feasible. It was a pilot study. And it demonstrated, because of course we all think, I mean, common knowledge is really to think, okay, acute kidney injury, I'm going to get fluid. I'm going to give fluids, but the kidney likes fluid. And of course, kidney doesn't like hypovolemia, but it doesn't like fluid overload. And these patients, they're quite likely to be oliguric and therefore to become fluid overloaded. So the hypothesis that we wanted to actually remove fluid or at least have neutral or negative balance in these AKI patients. And the study proved that we could reach a negative balance in these patients with acute kidney injury, and there was no increase in the need of renal replacement therapy, or rather a trend for a shorter duration of the acute kidney injury, suggesting that potentially congestion and factors such as this one might actually be a target for a patient with AKI, and maybe not just a one-size-fits-all and just give fluids to patients with increased creatinine. Well, that was the second trial. And then we discussed a little bit renal replacement therapy, in particular the question of timing, which has been a hot topic for the last 5 to perhaps 10 years. In many congresses, of course, you're aware that there's been all these large randomized trials trying to establish the timing, whether early initiation was associated with improved outcomes. Most of these trials, except for the Elaine trial, were negative, suggesting that you could have a watchful approach and just wait until you have actual indication for emergency indication for starting renal replacement therapy. And the group of Stéphane Gaudry from Paris asked themselves the question, how late can we wait? And that was the Akiki 2 trial, and they really tried to push it, because they included patients with stage 3 AKI and at least 72 hours of oliguria or a urea 40. And these patients, they're randomized to delayed, which was randomized starting the therapy, the renal replacement therapy at the time of randomization, or super delayed or very delayed therapy where they really waited. And here they found maybe the threshold, the tipping point, because in this study they found a signal for harm in terms of mortality. There was no benefit in terms of renal replacement therapy free day. So by waiting super long, you don't really save in terms of therapy. You end up dialyzing all these patients anyway, and there was really just not statistically significant, but a very strong trend towards harm. So that suggests that it gives us a little bit of a boundary. We can probably wait. And again, KDIGO criteria are not designed to determine the timing of artery initiation. So the previous trial have been mostly based on there. So we know that now that KDIGO 2, KDIGO 3, so tripling of the serum creatinine, it's okay to wait, but probably not too long, and probably not much more than 72 hours. I mean, that's what we learned from the Akiki 2 trial. Then we moved the discussion to the prevention of acute kidney injury. And here we had very interesting data from my co-chair, Alex Zarbok, and his randomized control trying to evaluate the benefit of the application of the KDIGO bundle. So, of course, we all think we're doing the right thing and doing all the measures that are recommended. And this KDIGO bundle is a bunch of very simple measures that we all think we do. But he's demonstrated in previous trials that actually most units, and even very good ones, are actually following just partly these recommendations. And that if you have a specific attention and you really try to apply these guidelines, you do decrease the rate of acute kidney injury. There was a Privaki 1 study. Of course, this was a single center trial that showed this decrease in the incidence of acute kidney injury. And he's moved recently to the multi-center trial, still a pilot trial. He's confirmed that in all these centers, indeed, the KDIGO criteria, the KDIGO bundle was not followed in the control group. And if you do, he found, although it was a secondary outcome, he found that the application of the bundle was associated with a decreased rate of acute kidney injury with a rate ratio risk reduction of about 10%.
Okay, so it was really a very full session that we had this morning with plenty of data. I think that, of course, we have a lot to discuss on this. And one of the points that you seem to highlight is the fact that we need perhaps to individualize lots of things. I mean, we discussed the fluids. Basically, there is no major impact, even though we have a tons of patients included. And nevertheless, we have some physiologic signal from small trials. So it seems that some patients may be harmed by saline. Perhaps, of course, some others should be helped. Do we have, from your look at the literature, some clues to help us to identify the patients that may benefit from one solution versus the other solution?
Well, that's a very good question. Of course, it's difficult. So if I knew, I could just tell everybody. But the interest of the PLUS trial was that it had physiological outcomes included, and they measured, because we felt the previous trial were a bit generic, and here they measured the pH of the patient on a daily basis, and they also measured the chloride serum concentration, and they did observe that the pH was going down when you give saline and you increase the chloride. Which is the hypothesis by which saline could be associated with renal toxicity in particular, through the glomerular feedback, etc. So by not having a mortality outcome, despite having these anomaly, it sort of reinforces the message that it might not be so important actually. But I would say that because these are the physiological alterations that we're afraid of associated with saline, and because this is what in observational studies have been associated with harm, potentially those patients that are already have alterations such as metabolic acidosis, hyperchloremia, and of course this is common in many of those patients, probably should avoid saline in those patients. I do not think they have really made this subgroup analysis for the moment, but potentially that would be part of the answer. If the derangement or the side effect that could be is already present to some degree, you don't want to worsen it too much. But that's only part of the answer.
Samir Jaber wanted to have a question to you.
Thank you very much. Just close to the question of Daniel, we are a little disappointed by the large randomized controlled trial in any topics, really. So do you have in the acute kidney injury field some positive trial, except neutral or negative, but some positive, not only signal as said by Daniel?
Yes, so, well, the Privaki trial is an example. I think this is one of the few trials that actually improved outcome, and there was an editorial from John Kellum saying, we finally shattered the inevitability of acute kidney injury. So again, this bundle, and the good news here is that it's a measure of, it's very simple measures. It's really controlling, making sure we don't give nephrotoxins, contrast agents, all these things that we all think we do, and I'm sure you do, but when you actually look in a trial, we don't always do completely. And so that's a very encouraging study to me. Of course, it needs to be replicated and really fully confirmed and validated. Otherwise, we need to move to, like, all areas of intensive care medicine and medicine in general into personalized medicine, and I really believe that biomarkers should be helping us. The problem that we have also is that we are working on a syndrome based, and acute kidney injury is a syndrome. It's not a single disease, and so obviously there won't be a single cure for septic AKI. Is not, it's probably different in its terms of phenotypes, cardiac surgery associated, the hypovolemia, toxics. The kidney is so complex, it's impossible that there's only one sort of disease that is leading. So I would hope that in the future years we can subphenotype acute kidney injury and stop talking about acute kidney injury, but acute kidney injury related to staphylococcal infection that triggers this, and or this related biomarker that's associated with this tubular cell issues, and actually dig down and have some some pathophysiological explanation, and then we can have targeted treatment and more likely to have a personalized or targeted treatment that's successful.
So thank you, Antoine, for having indeed pointed out this kind of questions that should be addressed in some future. We already put some date in our agenda. We want to meet you in 2 or 3 years with the answer to this topic, I hope, or at least to have some studies ongoing on that aspect, because I really think that, as you mentioned, individualizing therapies and taking into account some patient condition to say that we go on left side or right side is really something important. And by the way, it was a little bit the message of the tools you developed. I mean, we have to individualize the way we proceed with end of life. We have to individualize the way we proceed with the intubation of the COVID patient. And so thank you all for pointing out the real advantage of individualized medicine, even though we are not yet there at this stage. Thank you all, and good afternoon.
Thank you.
Thank you.
Bye.
Hello and good afternoon for Live Sport in Madrid, or good morning wherever you are in the world watching us. I am very delighted to be here with some of our faculty, Pedro Povoa from Lisbon, Katia Donadello from Verona, and Leo Heungs from Rotterdam. First of all, how is it going? The second day of the Congress, maybe Katia?
It is perfectly working.
Perfectly working.
Yes, absolutely, absolutely.
It's very
fluid.
Nice, very nice to be back face to face and lots of activities, lots of interactions. I know that some of you have been involved with some workshops. Maybe you, Leo, if I'm not wrong, something on mechanical ventilation?
Yes, definitely. We had just a wonderful afternoon yesterday and this morning, 4 hours of workshop organized by ESSIC. And we had around 80 people, a great faculty with so much interaction. We had fantastic discussions about the physiology of mechanical ventilation, the clinical impact. That was just a fantastic start.
Okay, I will come back to this later. And you, Pedro, what have you been involved with?
Today we've been doing a CBF again. This is the third time that we are running this type of educational activities. And this time again in 2 languages. We are going to we've done it in English and we are going to do it in Spanish tomorrow. And it is a very important way of discussing and learning, because we go back to basic things, those things that are in survivors of campaign that make a huge difference in improving outcomes of patients with the sepsis and septic shock in these last 2 decades without any new treatment or any new drug. It was just doing in a better way basic clinical work. And it was an excellent opportunity with interaction and debate with all the attendees.
I'm sure that we will get lots of questions. I remind everyone that you can send questions on the platform and we will try to answer all of those questions for you. We have some questions already about cardiac arrest, because I understand, Katia, you were involved in a live debate or a round table around cardiac arrest management?
Yes, at the end of this morning, we had a face-to-face discussion with Daniel De Backer and Claudio Sandroni. And we were, I might say, delighted about the interaction with the audience because the main topics were the use or not use of TTM or target control, temperature control as it is called right now, the use and implementation of eCPR and the importance of prognostication. So it was really
tell me something about temperature control or temperature management, because we've seen some studies recently. It seems that everything was negative, so some people say you should do nothing now.
Well, I believe that the saga is not ended, and we discussed this morning, because we might, yes, of course, we have great big studies that have highlighted the non-superiority of hypothermia compared to normothermia or to fever control. The problem is that the real target message that has to pass is the fact that if you take, for instance, the TTM2 studies, more than 50% of the patients had temperature control for more than 50% of the time. So it is not possible to think that doing nothing is the new rule.
Yeah, I agree with you. I was a bit provocative, but I have to say, I think it's important. We have a lot of young trainees watching us, and if you have to summarize a bit what is, what is the cornerstone, the milestones of good cardiac arrest care in intensive care, where would you focus your attention? What would be some message?
Well, first of all, as I said during the live discussion, I believe that the most important key message is the chain of survival. So we cannot pass away from it. And you can think about very big and interesting and original studies, but we have to stick to simple things. So identification of cardiac arrest, good quality CPR, be able to use a defibrillator, and to be rapid to all the different steps that come forward and next. So it is, as I said, it is absolutely mandatory to improve education, and you cannot improve what you can't measure. So it is mandatory to measure what you do to improve what happens locally.
I like what you said about simple things, but done well. I suspect there is a current theme also about some of the topics of the other speakers. Is it also mechanical ventilation now, Leo, that we do simple things done well for everyone, or is it a bit more complex there?
No, I was exactly thinking the same. I mean, like we did in the workshop this morning, we were discussing very complex, advanced respiratory monitoring, which I'm convinced is very important for specific patient categories. But it starts with our chain of survival. It starts with limiting tidal volumes, plateau pressures, driving pressures, optimal PEEP. So you have to do the simple things right before you go into more advanced monitoring.
What is simple monitoring? If I am coming to your workshop as a delegate, what would you teach me? What is a simple monitor that I should have in all patients, and when would you step up to more advanced monitoring?
So again, the simple things would just measure your driving pressure. So the plateau pressure minus your PEEP. Very simple. And then is the discussion, I mean, if this is above 15, you start thinking, is this right for this patient? Or can I decrease driving pressure a little bit? So start measuring driving pressure. You have the view on the tidal volume right away, right? Measure inspiratory plateau pressure. And these are the simple things. I think every day you do it around in your ICU, you should do this on the ventilator. And if you do this right, you have a very important first step.
Can I come back to this? We have some questions about measuring driving pressures and measuring all this pressure. Does it make a difference if I'm measuring this in a patient that is completely sedated and ventilated, or more and more now we have patients that start to have some form of spontaneous breathing? And can you elaborate maybe a bit on that?
Yeah, sure. So as I tried to point out, for a patient that is sedated, does not have a breathing effort, assessment of driving pressure is quite simple, right? So we do an anti-inspiratory hold, you measure a certain pressure, and expiratory hold, and the difference is your plateau driving, is your driving pressure. I think that's fantastic work by the group of Giacomo Bellani from Monza, right here, that actually demonstrates that you can do inspiratory plateau pressures in patients on pressure support as well. I think you have to be a little bit more careful than in a completely, than in a patient on controlled mechanical ventilation, but at least measurement of an anti-inspiratory pressure in patients on pressure support can be done. And he has published a very nice papers on the certain quality criteria. So it is doable, and it might be helpful, yes.
And what is more advanced?
Again, but first, it starts with measuring your tidal volumes. It starts with measuring perhaps a little bit of the respiratory effort in these patients before you go into more advanced measures.
And how often should you measure them?
So the driving pressure?
Yeah.
I would say at least 3 times a day. I mean, if you do your morning rounds, I think as a good doctor, as a resident, as a fellow, you're going to check your patient a couple of times a day, right? And if something changes, you measure the driving pressure again. You take
and I suspect, Pedro, this is a little bit maybe what you were referring to about how to do also the simple things whereas in sepsis. I mean, the continuous reassessment is probably one of the interventions we've seen in trials that maybe is bringing some of the improvements that we've seen in the care of our patients. So.
Yeah, one of the things is the early recognition. And then the big problem that we discussed a lot is it caused by an infection or not? Because if you are going to treat a sepsis-like syndrome with antibiotics, is not going to work, and delaying the treatment of that condition that is simulating sepsis. So that's always a problem, almost always a problem in the beginning. And also how to deal with that and the need of reassessing the patient frequently and having a sort of a checklist to see if the patient is improving, why is improving, if it is not improving, why it is not improving, or it could be a pathogen-related problem, or you're not giving the right dose of antibiotics, or it is not an infection, something is mimicking. Another thing that we also discussed is the need to restore perfusion and how to do it, the discussion about the fluids, the discussion about the drugs, and how the interaction between the fluids and the vasopressors, and how we put all together in a patient, trying to individualize treatment as much as we can, because the patients are not the same and the infections are different, doses are different, the drugs we use are different, so there are lots of interactions that could make...
We always have huge debates about fluids and sepsis and what to do it and when, and you know, whether it makes a difference to do it now or half an hour before, but actually it's irrelevant if the recognition of this patient does not occur promptly. What should we do in our hospitals to make sure that we are not missing patients? It's very easy in the emergency department, or should be easier, but a lot of patients sometimes comes from the ward.
Yeah, that's I think important. That could be two areas that we didn't address in the CBF, but is if we have better monitoring, or it depends also of the amount of personnel that we have, the nurses that we have in the wards. And I think one of the problems that we had with the COVID, we have a huge amount of patients and maybe they were not properly monitored. Sometimes we receive patients with late respiratory failures because they were not recognized in a timely fashion. And I think in the future, with better monitoring and also with the better analysis of the biological signals, maybe we can preview earlier and detect earlier that patients that are going to deteriorate, and so to be referred earlier to the ICUs, and even not being necessary to be admitted if you just intervene early.
And Katia, you were mentioning simple things to clearly to recognize and to bring this patient. Hopefully they do the simple things well, but then these patients come to our intensive care unit. It's not just about temperature control. It's also very complex patients, usually very sick patients, and you know, we're very concerned not just about the acute physiology, but how they may recover and so on. Can you tell us a little bit more about that? What is the consensus of good care for these patients now?
Well, at present, when a patient is comatose after cardiac arrest, the consensus is about keeping them sedated for the first 24 hours and to delay it and to wait for any kind of prognostication for at least 72 hours. And what has been highlighted in the past less than 12 months is the importance of a precise and well-conducted pathway for prognostication, because the self-fulfillment prophecy for this kind of patient is very harmful and can be very, dangerous. So it is very important to have, I don't mind if it is a protocol, a checklist, a program, whatsoever can be used. The importance is not the name of what we are using or the kind of table or of scheme that is selected, but is terribly important to have a consensus and attitude which has to be parted and accepted by all the members of the staff. And when I say all the members, it is absolutely stressed on the word all, because in many reality we face the presence of a clear difference between what is a medical decision and what is a nurse acceptance.
Yeah, and the multidisciplinarity is very important. You worked in different countries, I worked in different countries, and these key messages is something very important. You see, when there is good team dynamics, all the decisions are better, and there is also less conflicts and better probably outcome for our patients. So
I completely agree.
So, Leo, is there anything interesting on mechanical ventilations on this very sick group of patients, cardiac arrest, comatose cardiac arrest patients, something that we should be particularly careful? The answer can be no.
When we're talking about mechanical ventilation, the answer is never no. So sure, there is interesting things, and very recently I became aware of a paper, and I have to remember the abbreviation, but it was something like cardiac arrest-induced pulmonary edema. And there was a paper that actually investigated development of lung injury after cardiac arrest, and it plays a very important role in the final prognosis of these patients, because ventilating these patients with higher pressure in one way or another, and it was not completely clear, but also affected their outcome. So I think it is interesting. I mean, and you can imagine, I mean, a large pressure on the chest wall for quite a long time may result in development of lung injury. So I think good, optimal mechanical ventilation after cardiac arrest is extremely important.
I think Katia wanted to add something.
Yes, because first of all, just think about intracranial pressure and the influence on intracranial pressure by intrathoracic pressure. And people who love hemodynamics, as you do, might agree with me. And think about think about the effects of carbon dioxide on microvascular attitude.
When you come to these meetings, we all have our passions and niches, but the reality when comes very interesting when you bring all the things together, heart-lung interactions and different syndromes. And if you see, you know, lots of patients with cardiac arrest, if they have some cardiac dysfunction, after some days, they have a picture that is very similar to sepsis. Some of these patients, they may develop sepsis, right?
And another issue, I just going back to, we wrote a short piece to ICM on antibiotic prophylaxis, and one of the big issues is the risk of having aspiration pneumonia during the resuscitation. And there are some people that think that those patients should have antibiotic prophylaxis. I'm not speaking on SOD or STD, just antibiotic prophylaxis during in the first 12 hours after intubation. And there are some data from some small trials, one from Barcelona in Spain, showing that in patients not only in cardiac arrest but are intubated because of some low level of consciousness, they would able to reduce the risk of early VAP comparing to those without prophylaxis, and that could also impact on outcome.
Very good. We have a question about going back to the recognition. Quick SOFA. Is it useful?
A quick SOFA. It's
maybe you can remind people what it is.
Yeah. So during the new consensus conference, it was developed looking at big databases, a score that could be done without any lab value and could be used everywhere easily to assess patients with high risk of clinical deterioration of poor outcome. And so what ended up to be is a score that is more specific for patients that are not well, but is not that sensitive to detect.
I'm not so sure that then we use it very well. It was a screening tool, and probably even with that, we were probably missing a lot of patients.
Yeah, and that's the big problem. It's low sensitivity. Yeah. So it is not even in the consensus, not a score to define sepsis. What is defined sepsis is SOFA score. And if you want to identify patients before clinical deterioration, so you have to stick with the clinical reasoning, and with all the defects, I think the SEERS could be helpful, and there are data that show that using SEERS you can improve management, improve outcome, and improve also the time that you give, for instance, antibiotics.
But back to the quick SOFA, maybe we can just to give a clear message at home. We should not rely just on one score.
No.
That's wrong. You can miss a lot of patients there. Yeah. And are definitions important, or actually you don't need a definition to recognize a sick patient in the ward?
No, I think that the thing when they are very sick is that it's very easy. Like there's always that say if you don't need a thermometer to show that the house is burning because it's burning. the issue, and if the patient is very well, it is also easy to see. But in between, there is a gray zone, and I think the best way is to use all the things you know, and if you are in doubt, just 1 hour later go and reassess the patient to see if you have more information on that. I think that's to stick just in one thing or one score, it could be quite dangerous to the patient.
Yeah, I agree with you. Can I ask you, moving on a slightly different topic, we are talking a lot more and more also with the society about patients and families and the fact that we really want to involve them more, but also help them to go back to a normal life or to an acceptable quality of life. And you're all experts on different fields, from sepsis, we talk about cardiac arrest, mechanical ventilation usually means sick patients that are with us. Do we know enough on how these patients recover after they leave intensive care? And we have more and more evidence on research, but actually I'm a bit disappointed that not everywhere in the world, I have to say, even where I work now, we've not been able to translate this to good follow-up care for intensive care and so on. I was just wondering, Katia, what should we do for patients with cardiac arrest management? Are we doing enough for them? Do we know how they can really improve? Because their outcomes sometimes can be very tricky from a neurological point of view and so on.
Well, first, I believe that there's a notion to be done. We are far away from being at the target because there is a sort of cultural turnover to be performed because we have this idea that intensive care is the last step within a hospital. So when a patient gets out from the intensive care, it is something so magnificent that is a sort of ended story. And
we're changing a bit that
yes,
now, but you're right, there is still a lot.
So for the families and for a part of the staff, we face the situation where the door of the ICU is closing a pathway. And this concept is starting to be destroyed. And I believe that we must create multidisciplinary program that will encourage and engage patients and family, not only to describe how they get back home and how, if they manage, they return to their previous life, because the quality of the life that is lived is absolutely different from the number of living persons. So,
and also the burden that families have, because sometimes a lot of these patients, they become dependent on their family.
Absolutely.
Some of them, they cannot go back to work. Immediately with COVID, with my group, we saw that a lot of patients, after 6 months, they were not able to go back to work.
Also because when you evaluate the neurological outcome, we might describe a favorable outcome that I wouldn't like to have for myself. I mean, after a problem, if I'm not able to go back to my work, or if I'm not able to just eat my breakfast alone or my coffee, for me it is a terrible change in my quality of life, and it is a very simple thing. So I cannot, we need to evaluate the quality of what we do and the quality of what they receive,
and what they would want, what they would like, and I think we need to involve more.
That need to be manipulated in order to be more performing on the quality of life.
Leo, probably the field of mechanical ventilation, ARDS, is one of the ones that we studied the most with long-term outcomes, and so I always find it fascinating when I have a conversation about a sick patient and to decide where to push the treatment in this moment is, how do we find a fine balance that what I'm doing now to fix a number because I hope that I will get the patient better is really giving that patient the highest chance to have a long-term recovery. It's not so easy. It's easy to say, but it's not so easy to do in that moment.
No, I think that's that's a very difficult question and difficult issue that we are facing basically every day. But on the other hand, I think we are doing better than a couple of years ago. I mean, I've worked in different ICUs as well, and I see if you look at the different ICUs, everywhere is the feeling that we should start earlier mobilization. We should prevent muscle atrophy, and it could be too early mobilization, perhaps in patients where it's not possible through electrical stimulation of the muscles. But you know, when I was rounding in the ICU, for some of the patients that were actually weaning the ventilator, I just thought, why is this patient in the ICU? Why is this patient not out there in the garden? Is there something that we can do as a kind of reorganization of our ICUs to make it more comfortable for the patient, and that makes it at the same time more comfortable for the family as well? Just as a small example, I've been working in an ICU where we developed a swimming pool for ventilated patients. And a lot of people would say, well, that doesn't make sense, a swimming pool for a patient on the ventilator. And I don't think it makes a huge difference in the sense of rehabilitation, but it makes a lot of sense from a cognitive and motivational perspective. Can you imagine as a patient being in a bed for 1 month, just for 1 month, not being in a shower or whatsoever, and then you're able to go to a swimming pool while being on the ventilator? Both patients and
it
families
sounds
think
fantastic,
it's
but
fantastic.
sounds fantastic. But the reality is that, and we've seen it also with COVID, our hospitals have seen that sometimes just giving you the bare minimum to deal with so many sick patients, it's what we had to do. And I'm not so sure we've been able to put this message out to the community and to raise the awareness of how important these different interventions are, also for the experience of these patients in the intensive care.
Well, I guess the COVID was a very special time period for all of us, right? I mean, resources were limited, et cetera, et cetera. But are we using all the resources we have? I think there's a lot of families that are willing to support, to help in caring for the patients, even while they are in the ICU. I think there is fantastic opportunities out there. So I'm not saying it's easy, but I mean, the ICU, I mean, there's a lot that we can develop in the ICU to make it more easy for patients and family to accept that they are in a certain situation and that they are working towards recovery. And now, if you are in a single room for 24 hours a day while weaning a ventilator, at some point it's so difficult to get the motivation right. And if you can change a few things, I think it can have a huge impact on the short, but also on the long term.
What about sepsis?
What I learned from COVID, I was involved in a project to define in 2020 core set outcomes for trials in different stages, and we involve families and patients at that time. So what patients with, let's say, 2 months, 3 months of follow-up, and was quite an experience to know what they really want as an outcome, that we're sometimes not dealing with those outcomes. They don't want to know what is their viremia or IL-6 or compliance or whatever. They want what is breathlessness, the problem of cough, myalgia, and those things that are sometimes very difficult to measure. And we, in our trials, we sometimes measure what we think is important and is important, but things that are quite objective. It's very difficult to measure some of the outcomes that they really like and they are important for them. And then we end up trying to make or to have scores that could be measured objectively, those outcomes. But for me, it was very important that the patients think very different from ourselves, and we, in our interventions, we have to measure also those things and what happened after 1 year or more to those patients, and the impact those interventions have in different things like pain, myalgia, sleep quality, and those things.
So, Katia, you want to make a comment?
Yes, I would like to say that in most realities, unfortunately, there are two things that, in my opinion, are still a niche, and are physical rehabilitation and psychological support. They are not most in public healthcare systems. They are not perceived as something necessary for the wellness of the patients and the families. And I believe that a big part of the future is on stressing the importance of
And I think partially we are responsible for that.
Absolutely.
I'm guilty as a president of the society as well.
You are
for
always
this.
guilty.
But what we are trying to do is exactly trying to raise this awareness now with the public. You know, we set up a European Parliament interest group that now is listening to us, and we're trying to bring these topics. And indeed, you know, patients and families, you've seen the website, there's new resources for it. It's exactly that. I think if we don't, in all our countries, you know, raise the awareness of why intensive care units are so important, not just during a pandemic, but actually in general. And really, we are there to support patients, families all the time, for surgery, for trauma, really all the time, and to support the rest of the hospital, and really to try to have good outcomes after. To have that, we need resources from physiotherapists, from rehabilitation, probably from follow-up clinics. And I really hope that Europe will listen to us and try to put blueprints for healthcare where ICUs is a continuum from the recognition and prevention of acute illness to how we bring patients to a better quality of life. Pedro, you mentioned that even if we don't have a lot of evidence about new drugs and new treatments, when you do the things well, things get better. But can you tell me in practice, if I come to your hospital, how does this line of good things and simple things that work well, from the ward, from the emergency department, do you have protocols? Do you have a way to work together with your colleagues?
No, what we set up after the pandemic was to be before, but then the pandemic was terrible, is we have a protocol in the emergency department that the patients with hypertension or hypertension plus fever, or that the patient is not well, they call immediately the ICU. We have a team that goes there and make a quick evaluation, and that team is responsible for the patient during all the time that it is in the hospital, in the emergency department, then goes to the ICU, or if it is not the case, then will be handed over to the emergency team. And also we have a team that is called by a protocol by nurses or doctors in the hospital, just to go there to see if there is any, it's not only sepsis, it's patients that for whatever reason they have a sudden change of level of consciousness, sudden decrease in oxygen saturation, those very simple things that could be recognized by the nurses. They call us and we go there. We have a 24-hour, 7 days a week team working on that. And according to the evaluation, the patient will be or come to us or stay there. That depends.
And since yesterday, there is also an application to help young doctors, probably everyone at the bedside. You participated in the project. Do you want to tell us something about their space?
I think it's a quite useful app, because sometimes young people have doubts of what to do. And I think that's a very helpful and very clear way and very fluid way to find I think in the great majority of situations of sepsis, what to do, what to prescribe, and to give also safety to the people that and trust that they are doing a good job.
I think if you remember when we decided what should be the philosophy of this application, we said we don't want to replicate what is out there. And we thought we want to do something that is going to be useful for the question, 3 o'clock at night, I am alone in the intensive care, how do I deal with this new infection? And we think that it is going to be useful for that.
And I think it was quite successful. Then I think what we have now to do is to have the feedback of the users. I think that's...
and I really, I ask everyone really, if you're a member of our society, or if you become a member of our society, you have access to this application for free. So use it and let us know if it's useful or not, or is something that we should change. Leo, protocols for mechanical ventilations, yes or no, or somehow in the middle?
Yes, we need protocols. Just to tell you how to set the ventilator.
So ventilation the same for everyone?
As a start, yes, at 3 o'clock at night, we have certain limits for volume, for pressure that you can use. We have decided when to go from controlled to supported ventilation. We have a protocol on how to wean patients from the ventilator.
I think maybe we need to clarify one thing though. When we have discussions about protocols, people think that you give the same recipe to everyone. What you're saying seems to me that you are giving a method to try to put a patient in safety with within some limits. Maybe we can elaborate a little bit on that?
Yeah, well, of course. I mean, I think an ICU or a patient would benefit if Maurizio is there 24/7, but you're not there 24/7, right? So we have to make sure that when the experts are not in 24/7, that people know what to do, that young residents, nurses that are not experts, or young colleagues that are not experts know what to do. And in these cases, I think that protocols are very helpful. But this should not be like you cannot deviate from the protocol. I mean, if you have a good reason that for this specific patients, we accept higher pressure, lower pressures, we take more time, less time weaning the ventilator, that's perfectly fine. It will improve outcome. But for the whole group, I mean, we have a certain agreement how patients should be ventilated, right?
I'm very proud that we talked for nearly 40 minutes without talking about COVID. We just talk about everything else, but I cannot do it without COVID. So COVID, of course, is being also a great experience of learning for us, especially in the field of mechanical ventilation. A question for you. Is it so different as anything that we've seen before, that what we've learned will be difficult to bring forward? Or is actually some good things that we learned from COVID that will be useful also in other infections, in other RDS?
Well, at least what I have seen in my ICU is that even people that were not that much interested in mechanical ventilation before COVID are now very excited in looking into driving pressure, are excited into looking at the CAT scan and see, well, there is consolidation. This patient might be recruitable, and this patient with all ground glass may not be recruitable. People are now actually looking at P.1 as a measure of respiratory drive. So for the whole group of doctors, nurses, physiotherapists, the interest in mechanical ventilation has increased. The use of prone positioning as well. And even now COVID is gone, at least in our ICU for the moment. Still, people are very keen on having good driving pressures, looking at P.1, other measures for respiratory drive.
And treat patients differently according to what are the needs there.
Definitely. I mean, we're thinking more about this. So I think that is, well, really an advancement.
What are you bringing with you from COVID? The good things.
The good things, I tell my residents that they have seen more ARDS in these 2 years that maybe I saw in the last 10 years. Because
I've looked at some maths from our institutions. I think we treated in 1 year 18 times the number of invasive mechanical ventilation ARDS on a normal year.
So in that area, I think that was a huge experience that I hope that they would never see this again. And they are much more careful, and I shared all the ideas that looking at the PO1, looking at the driving pressure, looking at putting the patient in prone position very easily without any problem, and assessing the compliance, resistance, everything, and also since there were so many patients at a stage that we developed a small app in Excel to measure mechanical power, because it was a way to put all the variables there. It is not proven, but again, it was a way to see if we were on the right side, on the wrong side, because to put all the variables together, and people were using that. And so I think it was also a good way to improve a lot, and I think now they ventilate ARDS much better than in the beginning, for sure.
I think that's if I can have just 1 second, I think that's a very important comment you're making about the mechanical power. I mean, it's a long and probably bumpy road to proving that mechanical power improves outcome. But what is happening at the bedside is residents, colleagues are actually looking at the respiratory rate, they're looking at plateau pressure, at tidal volume, perhaps at the inspiratory rate. So there's more awareness that this patient is on the ventilator, and if the settings are not right, we might damage the lung, we might damage the
And I
body.
think
So
that's a very important message that both of you are giving, which is, yes, protocols to try to stabilize the situation, but actually every patient is different. And what we've learned about titrating different settings for different physiology has been unique. We need to bring it with us. Katia, what are you bringing with you from COVID? It can also be bad things.
Good things. Interdisciplinary cooperation. These 2 years have shown us that together we can, and we can a lot. And humility and resilience, absolutely. I mean, we demonstrated that despite ICU is not a profit department, okay? All ICUs have negative bank account. But
I could question that. I think it depends. No, it's an interesting comment that you made, because it really depends on how we interact again with governments. Because if we really believe that what we do has an impact for our patients, then the value of that should be there. And I think that's something we have to work. Certainly we have to work in Italy, but I can tell you we have to work in many countries as well.
This is what I was saying. I mean, I believe that these 2 years have highlighted that we are a cornerstone part of the hospital and of the patient lifelong experience.
And I think what we really learn and what we taught actually is that, and I've seen this everywhere in Europe, is that spare capacity is not waste. That capacity to be able to admit a patient and to have a buffer, it's something that we have to learn to value more and more. And that I think, our societies have learned what it means when you don't have that spare capacity anymore. 1 minute to go, so I think it's time to wrap up, maybe just 30 seconds. If somebody comes to your mechanical ventilation workshop, what would they learn?
What they learn is, what I hope, is that they have read a lot in the literature about advanced respiratory monitoring, and now at the workshop they will learn how to implement this in clinical practice. You can read 1,000 papers about measuring esophageal pressure, but if an expert did not show you how to do it, discuss the practicalities, you will do it wrong in your ICU. So you go to the workshop. We will have workshops again in Paris. Make sure you are there, because it helps in the implementation of everything you read into your clinical practice related to mechanical ventilation.
You convince me. I'll try to come to the next one.
Definitely.
So Pedro, Katia, Leo, thank you very much for a fantastic debate. Thank you all for watching and for staying with us, and enjoy the rest of the meeting.
Hi, good afternoon, everybody. Welcome to this afternoon live discussion. I think we will have a very interesting 45 minutes ahead on three subjects that at the first glance do not have much connected, but luckily we have very good specialists. As somebody mainly working in neurointensive care, I must say I'm not a specialist in either of the three subjects, but this will allow me to ask all sort of naive and stupid questions, so that's very good. But I would hope that some of the spectators use the chat to ask questions as well, because it makes the discussion more lively. And so first I will introduce my panel. I'm very honored and happy with this panel. So it's actually a Belgian-London panel, apparently. So I'm Geert Meijver from Leuven in Belgium. There's Jan de Waele from Ghent in Belgium. There's Luigi Camparotta from London. And normally there should be online Susanna Price as well. And there she is. And it works, the connection. She can hear us, we can see her. Fantastic. And we will cover three different subjects. Jan, who is a specialist in antibiotic stewardship. Luigi will talk us through mechanical ventilation. And Susanna will talk us through the heart failure guidelines. And so maybe I want to start with an opening question to the three of you. And maybe I will start with Jan. And I will ask a very naive question, as I announced. Jan, what is antibiotic stewardship? How do you define this, and why should we care?
Well, Geert, there's indeed several reasons to care, and I'll come to that in a minute. But antimicrobial stewardship is actually a set of things you do in order to rationalize, optimize antimicrobial use in the ICU. And the main idea is to improve outcome, of course, but reduce exposure to antibiotics in order to as a consequence of that, reduce antimicrobial resistance, of course also reduce the side effects we often see related to antimicrobials. There's also cost is also involved, and especially if you're a pharmacist, then cost would probably be the top reason to do it. But reducing costs at the same time, of course, is another added benefit.
Okay, thank you. And now a respiratory specialist after a COVID pandemic. I mean, apart from that, we worked all really hard. Your field must have advanced amazingly, hasn't it, Luigi?
Yes, I think you're right. Thank you very much. I think certainly the awareness of the importance of mechanical ventilation has advanced, and we certainly understood a lot more. We understood about gas exchange, we understood about the role of spontaneous breathing, we understood how to care for patients outside intensive care as well, because of the incredible number of patients that we got. And so I think the expertise has gone, that normally was limited to the intensive care specialist, actually has gone outside the specialist area. And I think it's interesting to see how the appreciation of what we do within the intensive care, particularly the care of the respiratory patients with a respiratory failure, is becoming more general knowledge. And I think that is very good for the future, because we can understand a little bit more about the mechanics, understand more about the gas exchange, and everyone is asking now questions that before looked very specialized, and now they're becoming more common knowledge. So that's a good news.
Thank you. And now let's go to our remote guest who is in London, unfortunately. You should be here. I mean, it's fantastic here in Madrid. We miss you here. Heart failure. Is this, so that we know that there's the new guidelines. What do you think that general intensivists or non-specialist intensivists should know about this? Should they just know, no, I send them to a specialized center? Or what is the sort of the basic level of knowledge or of expertise that you would expect from a basic intensivist?
I really wish I was there. That's the first thing to say. I'm sure it's much better than, although London is lovely, I'm sure it's much better where you guys are. I think I would divide that into two parts. I'd say the first bit is to just be aware of what the cardiologists are up to with their patients. They are highly evidence-based and research-based people, especially the heart failure cardiologists. And they have high quality updated evidence that comes very regularly. So you will see significant changes in the medications that the patients that are on in your ICU. And sometimes you'll be stopping them. And I think it's very important that if you have stopped drugs that potentially are life-saving, that we make sure that we've got post-quick care discharge a way of making sure they're back on them. That would be the first thing. And then the second relates, I think, to the really sick patients that come with cardiogenic shock to our intensive care units. And if you look at how the guidelines are changing, there is incremental evidence to turn away from some of our more traditional holding type therapies and be much more aggressive about reversing the underlying cause. If the patient isn't improving with what you're doing and is moving worse in terms of their SKY classification, choosing a different strategy, and now turning your eyes to some of the more novel mechanical circulatory support devices. So those would be the two things. Awareness that what your patients are coming in on is changing, and awareness that interventions are changing, both interventional cardiology for revasc, transcatheter valve interventions, and interventions for mechanical support.
Very interesting, because I heard you refer to actually evaluating the response to therapy as a guide, obviously, and also maybe if the response is not as desired, to a different strategy maybe, because maybe you got it wrong. And yesterday there was quite a vivid discussion over here on guideline approach versus personalized approach, and one of the discussion points was fluid challenges. And now, as there was the example of giving a fluid bolus, and that would constitute somehow personalized medicine. Now how do we do that? Or what is there a novel approach there? Is there something, and I'm really talking from the viewpoint of a basic intensivist, with some basic, let's say, echocardiography skills. Where do I stop? What is a fluid bolus? When do I decide that it doesn't work? Those appear to be very simple questions, but actually they are not. So maybe you can elaborate a bit how we should approach this.
Okay, I mean, it's extraordinarily complex. So first up, to say that all of the studies that use a particular echocardiography to determine so-called volume responsiveness, remembering that we're all designed to be volume responsive, were done on patients who had normal hearts, normal pulmonary vascular resistance, definitely a normal right heart. So it's very, very difficult to use those in patients who have cardiovascular disease. And one of the most difficult things to say is whether a patient not only needs more or less volume, but also whether their cardiac function is completely normal, because we don't actually know what normal for critical illness is. And what we're just beginning to unpick now is to really begin to see and visualize some of the potentially harmful effects of some of our interventions are on the heart. So we're learning that we can induce restrictive right ventricular physiology, which can be very, very detrimental to the heart with ventilation. We know that if we use norepinephrine to support mean arterial pressure, if you look at myocardial blood flow using echocardiography, you can see that as your norepinephrine goes up, your myocardial blood flow goes down, and it's associated with alterations in global longitudinal strain, but they would look completely normal using standard bedside echocardiography. So we're shifting now from a sort of oversight of what the numbers look like to what the individual patient looks like, and then trying to take that back to understand the pathology better.
Yeah, that's very interesting what you say. It's actually, we try, instead of trying to bring the patient to normal, it's sort of we try to bring him to acceptable values. And it's probably there where we look to other organ systems as well. I mean, we try to see that the skin is well perfused, the kidney is peeing, and I mean, how do you take these extracardial organ systems into account when evaluating the optimization of cardiac function?
So it's a real challenge. So if you look at how we look after patients, for example, on extracorporeal support, there's an increasing move towards using bundles of care and multimodality imaging and functional assessment, particularly in the time around cardiac arrest. If we're looking at anticoagulation, procoagulation, hemolysis, again, we're trying to understand the individual patient. And what we struggle with is that the very devices that we use, for example, if you're using VA ECMO to try and support the circulation, it may give you flow and it may allow you to reduce your press or support, but the very device you're using is potentially harmful to the heart. So we are very much looking outwards now to see what we're doing to other organs, but we also need to get our house in order when we're trying very hard to protect the organ that is driving cardiogenic shock. Many of the things we do are actually harmful.
And maybe before I move to the other members of the panel, because managing anticoagulation is also always a challenge, and we tend to, at least in my center, we tend to postpone it more and more. Aggressive anticoagulation in patients on mechanical support, and sometimes we wait 24, 48 hours before we initiate it, because we often don't see that much harm, especially with heparin-coated circuits. What is your position concerning that? Is that wise? Is that unwise? Is that cautious? Is that uncautious?
I think you're exactly right in your approach. So you try as much as you can to tailor the anticoagulation to what the patient needs. So it's very different if you're using, for example, a Protect Duo or a right-sided impeller, where you can be quite relaxed about not anticoagulating the patient, obviously depending on the etiology for their shock, versus a patient who has a mechanical mitral valve, who's on a circuit, and maybe a VA circuit. Now that patient has a very, very different risk of thrombosis. So one tries to plot the hemolysis, thrombosis, and bleeding tendency for each individual patient. There's a very nice review that came out from Christophe van den Briele from Leuven recently, looking at exactly this and defining a strategy that looks at anti-10A levels and a number of parameters, working very closely with your hematologist to go for the sweet spot for that individual patient on that particular day, understanding their pathology and their trajectory. So it's not at all easy.
And do you think we should move from APTT to anti-10As in all centers everywhere, or do you think that the centers that still use APTT or ACT are still they still represent how it should be done now? Because we've moved to anti-10A, for instance, in our center.
So the emerging evidence completely supports a move towards anti-10A. ACT isn't sufficient for these patients, and APTT, as we all know, can be quite misleading. So not in isolation, but there is definitely evidence supporting a move towards anti-10A as the best monitor for these patients.
Okay, thank you. We'll come back to you later, but I have to give the floor to the other panelists as well, of course. Talking about mechanical support, Luigi, I mean, you must have seen the highest numbers of ECMOs in your career over the past 18 to 24 months. Can you tell us something about what you did in the beginning, what you would do differently when it comes to indications, settings? Because I can assume that that you've learned a lot and that we do approach things differently now.
Yes, thank you. I mean, the interesting thing about COVID-19 obviously was twofold. Was a new disease. Obviously, we didn't know what the prognosis was going to be. I mean, if we remember the first reports about ECMO were really unfavorable, really high mortality, so to the point that was discouraged the use. So obviously there was a lot of learning about that in the initial phases. And then we learned that if we apply the same criteria, let's say the earlier criteria, based on the availability, the local availability, actually mortality was very similar to the pre-COVID conditions. And in fact, the ELSO data in the Lancet reported a 31% mortality at 60 days and a 36% mortality at 90 days, which was very similar to the one reported previously. And even in the UK, we reported a 75% survival, which was very similar to the 74% survival, which was in the 6 years preceding the COVID-19. So we didn't see much difference. But I think what made a huge difference was the number of patients requiring, or at least being referred for extracorporeal support. And what we didn't understand at that time, what was the implication in terms of the time spent with non-invasive support and the likelihood of developing lung injury. Because what we know, one of the criteria is essentially the time spent intubated or mechanically ventilated. And so there were questions that we faced at that time. And I think those questions are still open, and we don't know that for sure. But I'm pleased to report that ECMO seems to be a very helpful modality of treatment. And even now, we published about couple of months ago in the intensive care medicine a study comparing ECMO versus similar cohort of patients who did not receive ECMO, and ECMO shows a 18% improvement in outcome. And I'm also pleased to say that that data has been duplicated or essentially confirmed in an Australian paper just published in the BMJ. So I think there is a role, but the extent and the indications, there will be some fine tuning.
And do you think, because countries have different policies before COVID when it comes to ECMO, and some countries were quite restrictive with a very limited number of respiratory ECMO centers. Other countries, like my own country, are very liberal, where there's a lot of ECMO. Who's right here? Because it appears that a more liberal approach actually maximizes the probability for a lot of patients to survive. Of course, the price is that it's very labor-intensive and very costly. Is there some way to know where the balance is? Do you think that some countries need more ECMO centers now after what we learned from the pandemic or not?
I think it's very interesting, and I think you make the right point to say, where is the balance between workload and essentially staffing and resources versus whether the individual patient will improve or will benefit from ECMO. We know that patient will benefit from ECMO from what we know. The question is, what is the right amount of resources? And that is very difficult. What I can say about your question, do we need more ECMO centers? We know from the Paris data that actually having a number of patients that we look after is essentially related to outcome. So having lots of centers doing very little ECMO will not further the care of these patients, I don't think.
And then one additional question on ECMO. So we put a lot of, so let's say the threshold was quite liberal, at least in my country. So you put patients on ECMO, and then you see no advancement in the lung for, let's say, 1 week, 2 weeks, 3 weeks, up to 4, maybe sometimes 5, 6 weeks. When do we define failure of therapy? Because there were vivid discussions amongst nurses, amongst physicians. Why are we still treating this patient? Yeah, but I know this one patient who recovered after 7 or 8 weeks. How do we deal with this? Is there any way there's some sort of a biomarker or radiological marker of improvement, of prediction of, okay, this patient has a probability to survive to hospital discharge at least, or not?
I think it's a great question, and this is a problem we face all the time. And what we have seen is that this problem has become more prevalent in the second and third wave, at least in the UK. And we know also from international studies that the length of stay on ECMO in the first wave was very similar to H1N1. And then it became more and more prolonged. And so the question is, how can we predict? And I don't think we've got a solution, because radiology is not really predictive. We know some patients who will have almost complete radiology after a prolonged period of time. Gas exchange obviously doesn't predict. The treatment is very unclear what will benefit in the long term. So I think we can't generalize, and I think that's the value of a ECMO center with a multidisciplinary team, with multiple specialties, including radiology, respiratory, rheumatology, because that decision is too hard to make as a single individual. Let's say the treating clinician has to be done within a larger MDT. I think that's my opinion.
Yeah, that's a nice and balanced answer. Jan, you haven't had the opportunity yet, but if we come from COVID as well, I think it's a nice bridge towards antibiotic stewardship, because many of those patients in a second phase developed secondary infections, not only bacterial infections, fungal infections. And then even patients on extracorporeal circulation, which makes the right antibiotic dosage even more challenging. How do you think antibiotic stewardship has evolved? Do we have new insights here? Are more people now inclined to move towards antibiotic stewardship programs? How do you see it? How has COVID changed that field?
Well, I must say, Geert, indeed, that COVID changed a lot in antimicrobial stewardship. And the funny thing, while in mechanical ventilation we've learned a lot and people were eager to learn, it seems that when it comes to antimicrobial stewardship, everybody forgot about it. Everybody forgot that it existed. What happened? And I'm specifically referring to the first wave. If we look at antibiotic stewardship, one of the things is involving colleagues from different departments. Now, the first wave, clinical microbiologists, they were all setting up their labs to do the PCRs. The infectious disease specialists, they were on TV explaining to the general public what COVID was. And the clinical pharmacists worked from home. So the regular meetings that people had to discuss patients, to discuss antimicrobial use, they were gone. Second, the sampling in patients with COVID, and especially initially, was minimal at most. Everybody's very reluctant to sample patients who were admitted with COVID, even when they were intubated and closed systems could be used. Our experience is, and not only ours in our hospital, but we know that the sampling rate was much lower, so we had little information to guide antimicrobial therapy. And the third thing is that, well, we failed to understand what the disease exactly was. So there was a lot of inflammation and it looked like an infection, so everybody, a bacterial infection, everybody was thinking there must be a bacterial infection. And there was a huge use of antimicrobials. In the COVID Unite study, the ESICM endorsed study, we've seen rates of 80–90% of patients being treated with antimicrobials, and not for 5 days, not for 7 days, not for 10 days, but for longer, for weeks often, without any information to guide it, not able to understand the inflammatory markers that we commonly use to guide antimicrobial therapy. And this led to an explosion of antimicrobial use, and following that also antimicrobial resistance. So people forgot about it, but it clearly showed that antimicrobial stewardship is a necessary thing.
So this is a rather, let's say, pessimistic view on how we did it, but how do we move on now? I mean, what is your sort of, as a voluntary optimist, I would say, how do you think we should go from now then? What is, suppose I work in a small hospital, I have no antibiotic stewardship program. Who should I convince? Why should I convince them? Do I need to convince the microbiologist, the pharmacist? Do I need to ask them to round with me? What will it cost? What will it deliver to the hospital or to the patient?
It is a specific challenge, of course, when you don't have a system in place. I always like to think of antimicrobial stewardship of having three important dimensions. The first one is the who of stewardship, who is involved. And typically, of course, a clinician is involved. We as intensivists need to be involved. I'm absolutely a believer that this is our core business as well. But you need the support from the lab, the microbiologist, and you need to go and talk to the lab, talk to the ID specialist, talk to the pharmacist, and try to get them on board. And of course, having support from the hospital direction is very, the hospital management is very important in this as well. The second dimension is the what. What are we going to do? And there's different solutions, different things. You can maybe you need to start using PCT. Maybe you need just to develop local guidelines. So it's really very dependent of the local situation. And some hospitals, when you don't have anything, you need to analyze your situation. And you take that's the first thing. And the third dimension is the how of stewardship. And this is about implementing all these different actions. And I think this is an excellent example where implementation science meets intensive care medicine. And where rather than just jumping like, okay, I've been to Madrid, I've learned about using procalcitonin. It's not about writing an email to your residents and your colleagues. From now on, we will be using PCT on day 7 or day 5. And if it's below, that's not how it works. That can be part of the thing, but you need to really start with analyzing your situation, see what the immediate urgent actions are, what the domains are where you're actually doing worse than or much worse than other hospitals, and then look for actions, and then also carefully plan and implement those as well.
So from what you say now, I take two messages. That is that there is no one antibiotic stewardship program, that it is sort of, it can mean different things. And the second thing is that it starts with analyzing or doing a survey of your situation. Now who should I ask to do the how should I approach that survey? How do I evaluate my baseline situation in my hospital and find the points of improvement?
It starts with measuring what you are doing, and of course identifying what you think is most important. Suppose you say like, okay, I noticed that the compliance with guideline of antimicrobial prescription is 60%, and we in our hospital, we think it should be 90%. Then that is an obvious target. If you would measure it and it's already 92, there's no need in trying to improve this. Maybe in that situation, your typical duration of antimicrobial therapy is 14 days. And that's another thing. And then you can say, okay, this is where we need to work on. And then try to identify why this is and look to design actions specifically aimed at. Is it because people have always done it? Or is it maybe because one consultant really likes to always give it or do it like that because we've always done it like that? So it needs a personalized approach, institution-specific approach, because the determinants are different. Maybe it's the lack of guidelines in one hospital. Maybe it's the presence of an individual who has a very strong idea about how long antibiotics should take. And maybe it's just we're not interested. And depending on what the cause is, that's where you have to act upon.
And what do you think is the role? Because more and more what we do now is that we sample and we dose the antibiotics in the blood. We do it for antifungals, we do it, and so it starts for more and more antibiotics, specifically in our group of critically ill patients where it's so unpredictable where we can get, and we actually can get it wrong in both directions. How do you see this evolve? And do you think that it's in the long run cost effective? Because we could save maybe on antibiotic dosage or optimize, but maybe we spend all that money on the lab then.
Yeah. Well, TDM for antimicrobials is a very exciting field. Well, I do also a bit of research on that. And yes, what we do know is that standard dosing results in highly variable concentrations in the blood and at the site of infection. It is linked to differences in outcome. So trying to optimize is a logical way to do. So definitely there's a rationale there. I think we're still trying to find out what the best strategy is. If measuring the concentration in the blood is enough, should we sample it at the infection site? I think at this stage, this is under research and it's a very exciting area, but it's not so easy to give evidence-based recommendations at this stage.
Thank you. And at the danger of sounding a bit like the Euro Song Contest, I think we should move back to London now, because we still have Susanna there and we haven't heard her for a while. Susanna, I have a question for you with regards to mechanical hemodynamic support. And what we see more and more is that we used to think of LVAD devices as a bridge to transplant. And we see them now more and more being used as a destination therapy. But this is going to be very, even for a rich country like the countries we live in, it's going to be economically very difficult to sustain. So how do you see that evolve? What are good indications? What are bad indications to see? Because we don't want people to just stumble accidentally into a destination therapy program. So it's supposed to be a deliberate choice even before you start it, even maybe when you put them on the ECMO. How do you see this evolve?
So I think I'll take that in two parts of the question. So the first thing is that if you have a patient who's in big trouble and has cardiogenic shock, you need to upfront know what the exit strategy is for that patient, because the last thing you need is patients who are awake on extracorporeal support who have no possible exit strategy and a heart that doesn't recover. So the push now very much is to have right up front team decision making as far as can be predicted, were this patient's heart not to recover but everything else got better, might they be transplantable? Whether VADs are funded as destination therapy varies widely across countries in Europe. So in the UK, unless you are transplant eligible, you are not. If it's predictable that you wouldn't be transplantable, then you are not funded for a destination LVAD. There's a problem though, because the upcoming left ventricular assist devices are now beginning to look at least as good in terms of outcomes as transplantation, without the need for the immunosuppression. So it's incumbent on us, I think, at the very acute end to make sure we're very clear what that patient pathway looks like. Is it that you're expecting that heart to recover, in which case everything you do is to make sure not only are the other organ systems supported, but that heart has the best chance? Or is it that you, in conjunction with your transplantation and LVAD team upfront, expect that the heart may not recover, in which case they may be potentially a VAD as a bridge to transplant, or a VAD, if you're in the country that has funded destination therapy VADs, that they're a candidate for it. The last thing you want to do is to save the patient acutely when actually you know there's no exit strategy for that patient. It's not fair for the patient, it's not fair for your team, it's not fair for the relatives, and actually one could consider that as causing harm. Going a little bit back to your futility discussion earlier.
Yeah, thank you. I think that's a very nuanced answer, and indeed will depend on a totally different note, on a different topic. Inotropes. I personally have the impression that we're moving away from adrenergic inotropes as much as we can, and that we move to phosphodiesterase inhibitors or calcium sensitizers more and more. Is this true? Is this impression correct? And is this the right approach? Like a combination of an afterload reducing drug and with maybe some noradrenaline just to have the inotrope effect and just keep the pressure. Is that better than combining the butamine noradrenaline, or how does that evolve, or what are the new insights there?
Okay, so the short answer is there's no high quality evidence to suggest that any one inotrope is superior to another. So, and even if you start looking at the use of norepinephrine as a pressor, when you drill down into which studies suggest that norepinephrine is superior, the largest one is a sub-study of the SOAP study, and it was never intended to look at patients with cardiogenic shock. So there's no clear definition of heart failure in there. There's no measure of cardiac function. So the quality of evidence that we have to suggest one over another is not good. There's clear emerging data to signal harm from broad use of epinephrine or adrenaline. So there's a nice study looking, it's a randomized controlled trial, it's relatively small, looking at adrenaline after acute myocardial infarction, and the composite endpoint of mortality and refractory cardiogenic shock was worse in patients randomized to adrenaline over norepinephrine. The CardShock study again begins to show a signal of harm. So there is a push to use something different, but we don't really have any evidence that the different is any better. There is a danger of using drugs such as, for example, levosimendan, theoretically really, really attractive. But in the very acute setting in patient with cardiogenic shock, where they may then go on to develop quite a profound inflammatory response syndrome, then you may well regret what you're doing, and you may be able to globally correct your mean arterial pressure. You may be able to look at some measures of perfusion that are good, but you don't really know what you're doing to regional vascular beds. And what these agents do, although they share one feature, which is they increase TPDT, they increase contractility, they're very pleomorphic. So what they do to microbe transition, what they do for your redox status, what they do to regional and microcirculatory performance are very, very different. So we are moving away from the things that we know cause a lot of harm towards other drugs, but we don't yet know that they're better, and we're not yet good enough at measuring what they do in specific regional beds and what all of their actions are.
Fantastic. I love the way you structure your answer. It's so it's even as if I see your slides in front of me. So very good. Thank you. Luigi, we've discussed ECMO with you, but we haven't actually discussed mechanical ventilation yet. And I think after COVID now, I think everybody thinks they know how to ventilate patients, and they're all experts in ARDS ventilation and in proning and in... But are there still things that we sort of systematically do wrong, or that go wrong on a long scale? You as working in a tertiary referral center, you might know what still goes wrong, or where we can still improve in just setting a ventilator in an unconscious patient.
Thank you very much. I think one of the things about mechanical ventilation is that it's like every therapy in medicine. It's very difficult to generalize, and I think perhaps one of the things that we can generalize is that measuring things at the bedside, it would be one step forward. So one of the things, sometimes we get referrals for patients with severe respiratory failure. There is the treatment that is evidence-based, almost like a recipe, but there is the measuring of mechanics, the measuring of understanding of other criteria of gas exchange, of things that can really help stratifying that patient into the severity category and also the kind of treatment more likely to be beneficial that is still missing. Particularly in patients who are spontaneously breathing, there is very little measurement of the respiratory effort. And I think one of the things we could do is start learning perhaps the 3-4 things that are really important as a baseline and start doing it regularly. A bit like what you were saying about measuring with the antibiotic stewardship and where we are, where we should be, is actually understand how many times do we do measurement of static lung mechanics, how many times do we do measurement of inspiratory effort, how do we understand the level of pressure-supported ventilation, how many people do we do prompt positioning and how many we missed. For example, a study that we published about last year, it was very clear that lots of patients missed many opportunities of prompt positioning, particularly in the first wave. So I think the measurement is very clear and understanding what is important. Clearly not advocating measuring everything, but there are only very few things that could make a huge improvement in the care that we deliver, particularly in the field of mechanical ventilation. So,
and does this mean you would advocate that we more routinely use measuring of diaphragm function, put in esophageal balloons, or is those the type of measurement that you think that should go into routine practice, or do you think this is more something for specialized center to gain pathophysiological insights, or is this something that, let's say, a clinician with some interest in mechanical ventilation can actually learn how to do it and adapt therapy according to it?
I would go even one step more basic, and I would look at, for example, in our database for referring, patients who refer to the UK, plateau pressure is missing. The idea of knowing what the static compliance is missing. So I think simple static measures would be very helpful at the beginning. And then even simple things like an occlusion pressure, a P01, simple things that give us an idea that can be done with any ventilator, non-invasively, without esophageal balloon. That can be done. I understand that the more invasive it gets, the less is going to be done. I mean, esophageal balloon was only 1.2%, I think, in the lung safe, so very small. Hopefully things will change, but in the meantime, we can use our ventilator to best advantage, I think, with simple maneuvers.
I heard you mention patient-induced lung injury. So this is a huge point of discussion now. And I used to be not worried when the patient was breathing by himself. I was not worried at all because I thought that would be by definition good. And now this morning I heard Antonio Pesente say the patient doesn't always know what's good for him, which is sort of attacking the conundrum that we now appreciate in most patients, that we say, okay, usually when we leave them alone, it's fine. So as a clinician, how should I detect patient-induced lung injury? What are signs that I need to look at? Is it just tidal volume, or is this other signs I can look at? And what can I do about it? Because I would be very worried to resedate a patient and ventilate them when they're spontaneously breathing.
Yes. I mean, the thing is, the tidal volume is not really giving us a good indication, because a patient might be completely normal, with a completely normal lung, have normal tidal volume, and we certainly wouldn't paralyze that patient. So I think we need to look at the two sides of the equation, which is what is the cost to the patient in terms of lung pressures, lung strain to develop or that tidal volume. And that's where the muscular pressure measurement is useful. It's only a maneuver, an end expiratory hold maneuver, and we can measure it on the ventilator. And that will give us an indication where that tidal volume has been produced at great effort or whether it's been produced by normal effort. And that will be able to identify the patients that able to breathe spontaneously and therefore fast track towards weaning, and the ones that are still not ready, where the lung inflammation, the respiratory drive are dysregulated. And obviously I agree with Antonio Pesenti. Patients don't know, because what comes to the brain from the lung, from the chemical, are dysregulated. The patients are still critically ill. So we need to monitor and understand what is safe, what is not safe. Yeah.
Yeah, and that's an interesting point indeed. When to continue, when to go ahead, and when to stop. And this is something we used to do rather intuitively. We would look at the patient. And I've always wondered to what extent the psychology of a patient plays a role, because there are some patients where we sometimes think, like, physically we assume that this patient is ready to wean, and there's some sort of anxiety or psychology that we somehow cannot overcome. Do you recognize this? And is this, I want to discuss it with Leo Hunks, who said it's an exclusion diagnosis. First you have to exclude all the rest. Or is there something you can do more proactively? And how do you see the role of, for instance, psychologists, relaxation therapists, and people like that who could help in overcome this problem?
I think his very good point, and the experience of the patient, whether it's this dyspnea, whether it's air hunger, that are real feelings, and the sensation of effort is multifactorial. There are some automatic components, there are some emotional components, so those things are not to be underestimated. And that's why I think one of the things is understanding through measurement, and then the value of MDT. We are very lucky within the intensive care that we are not single specialists. We are within a large group, and we should make use of all the specialists and specialism that you mentioned, like psychology, social workers sometimes. There are patients that have anxiety about various other things that can be addressed by non-medical support. So yes, it's complex, but it's a complex problem, but we've got the opportunity to start solving by unpicking little things one at a time.
Thank you. Moving back to Jan on antibiotic stewardship. So over the, let's say, years, we've seen that duration of antibiotic therapy is being reduced now as part of antibiotic stewardship programs. Often when there's still active inflammation ongoing, and it's often very hard to make that difference between inflammation because of other reasons and infection, the classical question. Now, are we at a certain stage giving courses that are too short, or what are the dangers there? Because for the moment you see the trend seems to be, okay, let's say 3 days, 4 days, 5 days of antibiotic courses, that's fine. Is this always fine? Is this, what signs should we watch, or when should we definitely not do that? In what conditions should we not try to reduce the course?
That's the million-dollar question you're asking me, Geert. I'll try to give an indication of what we need to consider in these situations. Well, first of all, of course, current standard therapy would be 7 days, but you understand perfectly that bacteria have no idea
they have no calendar.
They have no calendar, they have no idea what day of the week it is. But 7 days somehow gives us this feeling of fulfillment. It's complete at 7 days. Now, of course, in some patients, this can be shorter. There have been trials in intra-abdominal infection, of course, always a bit more difficult because there's this impact of source control as well, which is very important. But when the patient is clinically doing fine, then indeed you can shorten to 3 or 4 days in some situations. An important, not easily measured element is the immune status of the patient. The immune system is, of course, also capable of reducing, treating, the handling the pneumonia or whatever infection, but it's very hard to measure it and to consider it in the whole approach. So we stick with 7. Some patients may need longer, others may need shorter. Also today in one of the sessions here, data were presented on the use of anti-pseudomonal drugs in Pseudomonas VAP, 8 versus 15 days, and non-inferiority was not actually demonstrated. So a lot of questions remain there. Clinical evaluation of the patient for me is very important, and if you are at 5 to 7 days and the patient is clinically doing fine, for most infections, and there are many exceptions, but for most infections, that would be enough.
Thank you. That's a very nice answer. Now we're almost at the end of this session, I see, and so I would like to give the floor to each of the speakers to give like a sort of a 30-second, 1-minute sentence as a sort of a end message they want to give to the viewers. And I'm going to start in London, of course, with Susanna, and then we'll move to Luigi and to Jan, and then we can probably wrap up the session.
Okay, so if I could have a plea for our most critically ill cardiac patients, I think the markers that we have for identification of cardiogenic shock, they're all late. It tells you that bad things have already happened. So if I'm looking forward, I'm looking towards artificial intelligence to help. But given that we live now, in the time that we have now, I'd make a plea to people to recognize it where it is now. Understand that hypotension is no longer in the definition, but hypoperfusion caused by the heart not working is there. Always go to treat the underlying cause. If you don't do that, your patient will do very badly. And if they're not responding to what you're doing, it's probably because you're doing the wrong thing and they need something different. And it may be mechanical circulatory support. So please, please refer early. Thanks.
Thank you, Susanna. Great message. And thanks for joining in. It was a pleasure having you here. Luigi.
Great.
Thank you. I mean, one of the things reflecting on the last 2 years was been that we've got 3 moments are very crucial to the patient. The time when we decide to intubate, the time when we decide to switch from control to assisted ventilation, the time when we decide to wean and extubate. And what all these 3 points have in common is clear measurements of certain things, whether it's mechanics, inspiratory effort, and the effect over time, so measuring changes in some physiological parameter. So if there was one thing I would say is about measurement, and again, we touched upon this earlier on, is it takes not very long time and just very few measures, but doing it routinely can really change the understanding of the patient and sometimes the time course. So that's my message. Measure things. It's fun.
Thank you, Luigi, and you as well. I want to thank you for being here. I think it was we had an amazing discussion here. And now Jan for the final word.
Well, I would like to focus on the problem of antimicrobial use currently in our ICUs. It's high, and the situation is getting worse. We are seeing increased resistance. There's new antimicrobials coming, but they're not so easy to use always. And we have new diagnostics in the pipeline as well that will make things even more complex. So, and this is why I would really emphasize and encourage everybody to implement antimicrobial stewardship teams. They have to be tailored to the needs of the institution, but they're absolutely necessary.
Thank you. And so with these wise words, we're gonna end the session. I thought 45 minutes would be immensely long, but actually it's too short because there's so many subjects that we haven't touched. Unfortunately, I think I didn't receive any questions through the chat, so I hope we have asked the right questions for you. But if not, I'm sure you can contact each of the speakers separately, and I'm sure they will be happy to answer any of your questions. I think I had an amazingly interesting past 45 minutes, and so I hope you enjoyed it as well. Thank you very much for watching.
Thank you.
Thanks, Geert.
Hello and welcome back from the TV studio from Lice 40 in Madrid. It's great to be here again with Nicole Ufermans, the editor-in-chief of ICMX, and Giuseppe Citerio, the editor-in-chief of Intensive Care Medicine. And in this Congress, we are releasing two papers, two studies that have been published in Intensive Care Medicine. We discussed one this morning, and now I'm very excited to know what's on the menu for the second groundbreaking release. Giuseppe.
Thank you, Maurizio. In the next few minutes, we will introduce Professor Meduri from the USA. He's going to present the result of a study we just published today and is available on the website of the society. And he will present low-dose methylprednisolone treatment in critically ill patients with severe community-acquired pneumonia. So it's a hot topic. Steroids, during the pandemic, we had a lot of discussion about the use of steroid. We have a lot of discussion of use of steroid in many pulmonary diseases, and I think that Dr. Meduri now will present the result of this trial that we just published. Please.
Thank you very much. I really appreciate it. So it's a low-dose methylprednisolone treatment in patients with severe community-acquired pneumonia admitted to the intensive care unit. The name of the study is ESCAPE, standing for Extended Steroids in CAP, and the study was funded by the U.S. Department of Veteran Affairs. So the purpose of the study, severe community-acquired pneumonia requiring ICU admission is associated with significant acute and long-term morbidity and mortality that is related to acute and chronic dysregulated systemic inflammation. So our hypothesis was the following: downregulation of systemic and pulmonary inflammation with prolonged low-dose methylprednisolone treatment would accelerate resolution of pneumonia and improve clinical outcomes. The rationale for 20 days of treatment was to support the resolution phase of a disease, to incorporate adequate glucocorticoid tapering, and to reduce post-hospitalization low-grade systemic inflammation that is the reason for long-term complication and death in these patients. Methods. So we use the 2007 ATS-IDS criteria for severity, multi-center study, 42 medical centers, VA medical centers, recruitment between January 2012 and April 2016, double-blind, randomized, placebo-controlled, recruiting adult patients within 72 to 96 hours. So the 96 hours was added later on in the study to allow entrance of patients that developed criteria for study entry, but were admitted initially not in the ICU, but on the ward. And this is a group of patients with higher mortality. Consent capacity was done through a protocolized assessment to verify capacity. Randomization was 1-to-1, stratified by site and need for mechanical ventilation. The management for severe pneumonia and for ICU care was protocolized, and patients received antibiotic concordant guidelines treatment. The sample size for the study was originally 1,420 to provide 85% power to detect 7% absolute reduction in 60-day mortality, the primary outcome, 28 placebo, 21% methylprednisolone. So this is the treatment protocol. The patient enters the study, is enrolled, is randomized, and now receives a bolus over 30 minutes of 40 milligrams of methylprednisolone that is followed by a continuous infusion of 40 milligrams a day for 7 days, 20, day 8 to 14, 15 to 17, 12, and then 8. So over 6 days, there is a tapering. During ICU stay, there was continuous infusion. After ICU, the patient received the drug with twice a day, intravenously or enteral. This is the assessment that was done on this patient. They were seen in the emergency department and then in the intensive care unit. Here we have randomization. The patient was followed daily during ICU stay, then was followed during the hospitalization after ICU discharge. He had an extensive visit at hospital discharge, and that was followed 3 times during the follow-up at day 28, 60, and 180 as an outpatient, and there was verification of records to determine mortality at day 365. Participants and endpoints. So we recruited 586 patients. 2 were not randomized, so 584 entered the study. That is short of a 1,420 target sample size. Time to initiation of treatment, within 48 hours, 70%, within 72, 94%, the median was 40 hours. Primary endpoint, 60-day mortality. Secondary endpoints during hospitalization, new shock or ARDS, MODS 3 days, mechanical ventilation 3 days, duration of ICU and hospital stay, complication, hospital mortality, exploratory mechanical ventilation duration out of mechanical ventilation 3 days. Secondary endpoints after hospital discharge, cardiovascular complication, quality of life, number and causes of rehospitalization, very important, at the hospital within 1 year, complication, all-cause mortality at day 180 and 365. So this is too long to go through, but you will see that on your website now, since I just found out it was published. And we have a total of patient randomized 297 in the methylprednisolone as intention to treat and 287. That's what I will explore. So let's look at the baseline characteristic. So patients are old, 69 have an average, 95 and 97 were male with major comorbidities I will discuss next. About 1/3 or more healthcare associated pneumonia. Admission from the ward is about 20-22%. Pneumonia severity index is high. PSI 4 and 5 in more than 80% of patients. Bilateral and multilobar pneumonia in about 60 to 70% of patients, with no difference between the grouping, anything that I'm going over. So then we have ARDS in a small percentage that we'll analyze later separately. Bacteremia in about 15% of patients. Mechanical ventilation. So 1/3 of the patients were on mechanical ventilation study entry, and they will be analyzed separately. Vasopressor dependent about 10-15%. Adequate antibiotic treatment based on guidelines, 98 and 95%. Now, comorbidity is very important. So we have frequent comorbidities. So 4 per patient, but look at this, diabetes, hypertension, dyslipidemia, those are associated with glucocorticoid resistance in 50 to 70% of patients. Obesity, 21-25, atherosclerosis, 45% and 38, COPD at more than 40%. And then we go to chronic liver disease, not chronic liver insufficiency, malignancy, but not during active treatment, about 20% of patients. And what I want to point out here, depression in bipolar disorder, about 30 to 34% of patients. Those are conditions also associated with glucocorticoid resistance. So this is the primary outcome. Intention to treat, 16%, 18%, methylprednisolone placebo. From now on, I will present, no significant difference. New shock and ARDS, no difference. Now, so then we found that there is non-significant changes, but there are something that needs to be looked into. So the duration of mechanical ventilation was decreased by 1.6 days. Mechanical ventilation 3 days by day 1 to 8 by 3 days. Duration of ICU stay by 1 day. ICU stay up to day 28, the same data. Duration of initial hospital stay decreased by 1 day. But even mechanical ventilation stratum, the reduction in duration of hospital stay was 2.6. And again, there was no significance, but clinically interesting data to look at. Now, this is the figure of the Kaplan-Meier curve for all-cause mortality, methylprednisolone blue and in placebo. So you see that they go together, then they differentiate a little bit as we go along. Now, let's look at the 2 groups. Mechanical ventilation, the difference is much wider than in the non-mechanical ventilation group. Again, non-significant. Now, primary outcome, let's group with a subgroup analysis. What we have here is mechanical ventilation, methylprednisolone placebo, 23 mortality versus 26, non-mechanical ventilation is the same. Then regarding the Apache score, what you see here is with a higher Apache score, there is here 9 versus 15, 33, not significant changes within the Apache score. Now, this is interesting. Vasopressor-dependent shock mortality is 15 versus 25, but the group of patients is very small to making any serious consideration. Mechanical ventilation alone, 18 versus 23. So we still see some noise around mechanical ventilation. Then we go to antibiotic treatment. And this is interesting. With adequate antibiotic treatment is 15 versus 19, but with inadequate, there is a higher mortality, did not reach significant, few patients in the steroid group. And this underline the importance of adequate antibiotic and treatment of the underlying conditions in patients that are started on steroid treatment. Now, time to treatment initiation within 48 hours, if treatment is within 48 hours, mortality was 13 and 13, but within 48 hours was 23 and 29. Now, regarding ARDS, we have 26 patients and 39. The mortality was 15 versus 36% with a trendish towards significance. In no ARDS, there was no 17% and 15%. So we see something on mechanical ventilation ARDS. Those are the subgroup analysis, and what you can see, everything is in this direction, but none reaching significance, and this figure is in the manuscript. Now, I want to bring up something about post-hospitalization outcome that is important. First, the mortality is 21 and 17 for methylprednisolone and placebo. The mortality is 7 and 6% for not mechanical ventilation. This is mechanical ventilation. Now, we look at what happened in the next 12 months. The patients that are hospitalized are the same, but there is double of a number of hospitalizations in patients treated with randomized to placebo versus those treated with methylprednisolone in both groups. Then I want to bring up something also very important, and this has been reproduced in many, many studies. The mortality was from 21 to 23 at 60 days, from 17 to 26 at 60 days. So there is increased mortality post-hospitalization. When we look at 1 year, it goes from 21 to 33 and from 17 to 38. So a significant increase in post-hospitalization mortality. So one thing that is important for intensivists, make sure that after the patient is discharged from intensive care unit, there is a long-term follow-up in this patient because they die from low-grade systemic inflammation that is clinically silent. Now, the post-hospitalization changes at 1 year. Not mechanical ventilation, mortality 20 versus 24. Mechanical ventilation, mortality from hospitalization to 1 year, 16 versus 23. The number of rehospitalization, 1 versus 2. All this is underpowered and they fail to show a reduction in rehospitalization. So we need continued research in this very important aspect. What about complication? Well, we have good news here. There is no increased rate of complication. And we carefully look at everything. So infection, ARDS, gastrointestinal bleeding, pancreatitis, anemia, acute renal failure requiring dialysis, neuromuscular weakness, and this was measured in all patients with digital hand grip manometry on several days. Psychosis, very important because of our patient population, or worsening psychosis, psychiatric syndrome, none with treatment. Very, very important. So safety is consistent with updated meta-analysis of ICU patient with pneumonia, septic shock, and ARDS, and underscore the safety of prolonged, I mean 3, 4, 5 weeks treatment in this patient population. Study limitation, early termination, insufficient sample size, therefore underpowering. We randomized 584, plan 1,420, so 41%. Baseline mortality was 18% versus what we anticipated, 28%. So less sick population, or at least with a lower mortality than expected. Generalization, those are veteran patients, elderly, white, male with multiple comorbidities associated with glucocorticoid resistance. So the trial may not be generalized to non-veterans. Timing of initiation can be very important. Usually, glucocorticoids should be started within 6 hours. We end up with a median of 40 hours. The dose of 40 milligrams may be inadequate to achieve glucocorticoid receptor saturation for optimal anti-inflammatory response. It usually is achieved at 80 milligrams or larger. Now, a lot of hospitals were involved. I want to thank you for the outstanding work that was done. There were a lot of, I also want to recognize the chairman office, the executive committee, the data safety monitoring committee, the clinical evaluation committee, the coordinating center, the clinical research pharmacy coordinating center, and the auditing, monitoring, auditing, and review team. Now, if you allow me 5 minutes, I can give you some personal observation, and otherwise I'll go straight to the questions. Do I have 5 minutes?
Go ahead, Dr. Meduri.
Thank you very much. So, since we study design and initiation, so we talk about 10 years or longer, there has been literally an explosion of research on glucocorticoid receptor alpha. Look at this, 23,500,000, okay? You pick up with Google just in less than 1 second. An explosion that has a huge impact on critical care medicine. So glucocorticoids, what do? They change their function during the course of critical illness. Initially, they potentiate innate immunity and mitochondrial biogenesis. So they are not immunosuppressive. Then they move to the anti-inflammatory and antioxidant phase. And when this is successful, they move to restoration of anatomical function and in adaptive immunity. So very, very important. This is why it needs to be treated for more than 7-10 days. We need to go to several weeks to support this part of the treatment, but at a lower dose. And also there is a significantly improved understanding of pharmacological principle that guide treatment. Now, during COVID pandemic, what happened? Well, what we have seen in intensive care unit is a significant variability in the response to treatment. So we give the same treatment to patient, the recovery or the methylprednisolone protocol, whatever you want, but we saw a different response in different patients, and we were forced to adjust. And we adjust by adjusting the dose and duration based on marker of inflammation, CRP, ferritin, etc., oxygenation markers, and so forth. So we developed this spontaneously based on the nightmare that we had in front of us. And this factor called attention to something very, very important that has been underappreciated aspect of glucocorticoid treatment. There is great inter-individual variability in both the blood levels that we achieve when we give the same dose and how to the same concentration in the blood the cells respond. So let me show you now 2 studies very briefly. This is a study that we've done in patients with the RDS. And these are methylprednisolone levels in the patient over time, okay, in 20 individual patients. Here we give a bolus and they go up. Then as we go with a continuous infusion, we achieve a steady state. But you see within each one great variability, and there is more up here, but I had to stop. So it goes up to here, the variability. So there is a medium level of 200 nanogram per ml that we reach here during the steady state, but there is a variability, a range from 50 to 820, so 10-fold difference. So I give the same drug. And then every day that the drug is administered, there is a huge variation. Although the variation decreases when you use an infusion to come to the bolus. Now go to the next study, fascinating. So those are 40 healthy volunteers. They get the peripheral blood mononuclear cells from this patient and they stimulate with concalavenol. And what happened? The cell is activated, and on the activated cell, they expose it to proportional higher doses of dexamethasone. And then they look at the response. That is inhibition of lymphocyte proliferation. That is a simple marker from rheumatologists for inflammation. And what you see here with the same dose variation, same dose variation, same dose variation. So variation here, variation there. I can go with a high dose and I still see variation. I can go with a low dose and I still see some variation. But something very, very important there is here, that even if there is variation, as we go up with the dose, okay, the response is greater. So this is very important, and that's what we observed during the COVID. We go up with the dose, and we see a response that we didn't see at a lower dose. So this is very, very important. So this is very unpredictable, and that's something that is very important. So what do we learn from COVID? What have we learned from positive, negative trials? That maybe the one-size-fits-all doesn't work. This is what we do now. Fixed dose, duration of treatment, no use of inflammatory markers and clinical response to adjust dose and duration. And so we have variable outcome. But maybe a proposed new approach is the following: an individualized dosing, individualized based on severity of illness, baseline inflammatory markers, with daily monitor of clinical response and inflammatory markers to guide adjustment. And this may improve the likelihood of improvement and decrease the risk of complication. And I think that's where we should go with the future randomized studies. Thank you very much.
Dr. Meduri, thank you very much for your talk and also for your comments. I am going to ask Giuseppe maybe to make a comment on why this paper was important. Why did you think it was important? And then we have some questions, and I also have some comments to make.
Okay, thank you for your presentation and for your comments. I think from a journal point of view, the question of use the corticosteroids as you presented also has been renewed during the COVID pandemic, so we were interested to understand, even if the trial has been enrolled patient till 2016, we discussed earlier with Maurizio, so I would like to ask you why you did publish so late the study, and going in the direction of your comments, which could be the next step for example, enriching the population. We saw the effect in mechanical ventilated patients, and how could be next for demonstrating this potential utility of steroids in this setting?
I mean, that's what we have seen, I think, in the COVID. Patient on mechanical ventilation, patient require oxygen. The sicker patients seem to respond to steroids versus patients that are less sick. Why the study? Technically, the study was supposed to be submitted 3 years ago. And then we had COVID. And unfortunately, the center dealing with the statistical analysis was outside of the chair's office or the principal investigators, was the one assigned from the Veteran Administration to deal with all the new COVID studies. And so that brought a 2 years and longer delay. Then there was a 1 year delay in the acceptance of the study by publication. So I'm happy that you finally accept it. So it was in limbo for 1.5 years between journals, and finally was accepted by you. So I thank you very much for that. I think it's an important study. We can learn a lot from this of what to do and what not to do.
Thank you. Dr. Meduri, congratulations again. However, if I look at the data that you presented, overall, most of the results, they seem to be negative, maybe with some trends. It was very interesting what you presented on ARDS. I was wondering, do you have any data on the effect of, for instance, PFO2 ratios and the degree of hypoxia on these patients?
No. So we know that the PO2 and FiO2 ratio baseline was similar between the two groups, but we have not looked into if that impacted. So I assume that the patient that had the ARDS, in addition to a worsened PO2 and FiO2 ratio, had other criteria to meeting the Berlin definition. So they were sicker patients.
Okay, Nicole, any questions?
Yes, Dr. Meduri, also from my side, congratulations on, again, an important study. I think it's important to reflect on your population, which is a little bit peculiar, as they are all male, but also the age is quite high, it's 69 years of age. Do you think that this is an important factor of why you fail to see any differences in outcome? Can you reflect?
So I cannot exclude that maybe that impacted that. So what we know is aging, the process of aging is interesting enough, a process associated with glucocorticoid resistance. And the glucocorticoid resistance is accompanied by low-grade systemic inflammation that leads to premature death. So they go along. So it's possible that is one reason why they do not respond. They have not responded as maybe we could have expected with a younger population. I want to point out that the original paper by Confalonieri back 16 years ago, the first paper on steroids in community acquired pneumonia, severe community acquired pneumonia, found that in essence only the mechanical ventilation group was the one that responded. Then the average was significant for all groups, but the subgroup of mechanical ventilation was the one that really had a response to steroids. And there was a younger group that we want presented here.
Well, we know about the phenotypes in ARDS and in sepsis, and it seems that there's hyperinflammatory and less inflammatory. Would you agree with this, or what would be your suggestion to these phenotypes?
So yes, there is data on community acquired pneumonia from Dr. Torres that those with an elevated CRP are most likely to respond. And so it is possible that the hyperinflammatory may respond more, but the interesting thing is may respond more to what? One dose. It may respond to a higher dose. So that's what we don't know. So that's the stuff. I personally am very simplistic in this after 30 years of investigation in this field. What we know and what we have known from COVID, in essence, the patients die from massive systemic and pulmonary inflammation. This is it. Also, what we know is there is no other intervention other than glucocorticoid treatment or corticosteroid, whatever you want to call it, to bring the inflammation down. There's nothing else. Some people have tried statins, but statins don't have any effect in inflammation for 14 days. And many other interventions directing on one single molecule really have no effect. It's a global response with literally thousands of different mediators. Methylprednisolone impacts thousands of mediators. So it's not that simple. So I think that what we need to do in the future, we need to be open to understand best way to use glucocorticoids. We cannot go the way we've done now. One example is the recovery trial. I mean, I spent good part of my COVID time talking to people across the globe. They start the COVID, the recovery trial, they stop the drug at 10 days, and 2-3 days later, the patient is back on a ventilator. So we really need to apply pathobiology, pharmacological principles, as we do for mechanical ventilation, as we do for vasopressors, also to the use of glucocorticoids. So yes, this study is very important, but this study and all the other study before this one have used a single protocol. There was no adjustment based on patient needs. And I think we need to move in that direction. Once we move in that direction, we can address the issue, are the hyperinflammatory subtypes more likely to respond to a higher dose? Are the hypoinflammatory maybe not likely to respond, but we need some adjustment? And then one more thing, steroids alone are insufficient. Steroids need a functional mitochondria, otherwise they don't work. So the supplementation with vitamins, vitamin C, vitamin D, is essential for glucocorticoid receptor function. So we really need to move to a global way to look at all these factors that impact our ability to regulate the inflammatory response. That includes not only inflammation, but also support of mitochondria and micronutrients depletion that is very rapid within 6 hours of critical illness.
Okay, we have time for one very last question. With COVID, we've got quite a bit of experience on the use of steroids on very sick patients. But there was also some data about prolonged use and exposure to steroids and possible secondary infections. In your study, you didn't seem to find any signal on that, not even on fungal infections and so on. How do you explain it? Was it a less sick group of patients, or how can you comment on that?
Yes, so randomized studies that have used prolonged treatment have not found an increased rate of infection. Randomized studies that have used infection surveillance to identify patients in the absence of fever, so with frequent sampling and so forth, found no increased rate of infection. In patients with ARDS, there is a reduction in the rate of infection. What is very important to understand is that this regulated systemic inflammation impairs innate immunity, impairs the ability of neutrophils and monocytes to function, to ingest bacteria and kill bacteria. When we decrease the transcription of inflammatory cytokines in immune cells, they're better able to digest and kill. Now, what is interesting about this study, that despite the fact that we had a large proportion of patients with diabetes, that is a high risk in certain countries for mucormycosis, we have not seen any increased rate of infection in these patients. So one important thing to do that I always stress, when you use steroids, you have to implement surveillance. Steroids blunt the febrile response, so that you need to use criteria other than fever to suspect an infection. These criteria are, there is a plateau in the improvement. Lung injury score come down, now plateaus. A plateau in the multiple organ dysfunction score coming down. There is an increase in immature neutrophils. There is an increase in minute ventilation requirements. When you have this suspect infection, go and do blood culture, check the lungs, etc., etc., etc. So also this is very important to identify infections in the absence of fever.
Okay, fantastic. Dr. Meduri, congratulations on your study, and thank you for staying with us today. And I would like to thank also Giuseppe Citerio, Nicole Ufermans, and remind everyone, if you have some important research, submit it to our journal, to Intensive Care Medicine and to Intensive Care Medicine Experimental. Thank you.
Thank you. The best, guys. Arrivederci.